All right. I'd like to welcome everyone to today's Assembly Health, Aging, and Long-Term Care. We're going to start, obviously, with the executive session. Let us first start out with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right. Thank you once again. I'd like to remind everyone that we are on WISI this morning as well, so make sure and silence your cell phones and devices. And with that, I will ask the clerk to take the roll.
Moses.
Here.
Rosar.
Here.
Brooks. Summerfield.
Here.
Murphy. Dietrich. Here. Gundrum. Here. Vandermeer. Here. Magnifici. Here. Shutt. Here. Sapek. Here. Subek. Here. Reamer.
Here.
Vining. Anderson.
Here.
Drake.
All right. We've got a quorum. We're going to be executing on 7 bills today, and a reminder that committee members must be present to vote. We're going to start with Assembly Bill 117. So with that, I'm going to ask Ledge Council to please briefly summarize Assembly Bill 117 along with the Amendment 1 to Assembly Bill 117.
Assembly Bill 117 requires a health insurance plan to provide coverage for supplemental breast screening examinations and diagnostic breast examinations when a covered person is at increased risk of breast cancer or has heterogeneously or extremely dense breasts. Supplemental breast screening in the bill means a medically necessary and appropriate examination of the breast, including examination using a breast MRI or breast ultrasound. Diagnostic examination means a medically necessary and appropriate examination of the breast, including an examination using diagnostic mammography, breast MRIs, breast tomosynthesis, or breast ultrasound. A health insurance plan may not impose on a covered individual a cost-sharing amount for supplemental breast screening examinations or diagnostic breast examinations. Assembly Amendment Number 1 changes the definitions of diagnostic breast examination and supplemental screening examination to remove all included examinations except ultrasound.
All right. Thank you, Ledge Council. And that was a brief summary. Do I have a motion to accept Amendment 1 to Assembly Bill 117?
I have a question.
Can we make the motion first and second, and we'll have a discussion? So motion from Summerfield and second from Sapek. All right, now do we have any discussion? Rep. Vining.
Thank you. So we're talking about whether or not our vote on the amendment, correct?
Yep.
Ledge Council, could you please clarify what is it that Wisconsin women do not have access to after the amendment? What does the amendment take away from the original bill? What kind of screenings? What kind of coverage?
Under Assembly Amendment 1, it removes the definitions for breast MRI, breast tomosynthesis, diagnostic mammography, and screening mammography. And those definitions are removed from the broader definitions of diagnostic breast examination and supplemental breast screening.
Okay, thank you. Is this now when I would give my comments on the amendment votes?
I'll allow you. Yeah.
Okay. It's going to be a long day, so I think I'll reserve the majority of my comments for the floor. But I do want to note that I think that Wisconsin women deserve the original bill. Without the amendment, I don't think that the insurance industry should be able to come in here and roll back what we're covering for Wisconsin women. And I am thoughtful about the women and their families who will lose life because we're choosing to cover less today. So I think we can and we should do better. I'm going to be a no on the amendment.
All right. Do we have any further discussion on Amendment 1? All right. Seeing none, the clerk will take the roll.
Moses.
Aye.
Rosar. Summerfield.
Aye.
Dietrich. Gundrum. Vandermeer. Magnifici. Shutt. Sapek. Subek.
No.
Vining.
No.
Anderson.
No.
Drake.
Weimer.
Reamer. Oh, I didn't even see you here, sorry. I didn't even see you, so I just skipped over your name, I'm sorry.
No. You have remarked present, though, correct?
Yes, I do.
You're wearing light colors, so you're not visible.
Comes into the wall.
9 to 3.
Passes 9-4. And everybody the committee members got shifted around a little bit from the sergeant's office here, so. I'll entertain a motion to recommend passage of Assembly Bill 117 as amended. Representative Rosar, and second from Representative Summerfield. Do we have any discussion on Assembly Bill 117? Representative Rosar.
Thank you, Mr. Chairman. I have to say I am a little disappointed that the amendment was brought forward. I mean, I will support it because I think I obviously did support it because it's a step in the right direction. I just want to share a personal story. After we heard this testimony, and this may be too much information for people, but I am a nurse, and you never want to have lunch with a nurse because you just never know what's going to come up, okay? So I had a mammogram scheduled for the next morning, and because of my history of dense breast tissue, I talked to the mammographer about what the recommendations might be for some supplemental screening. She sent a note to the radiologist who called me about 2.5 hours later to have this 40-minute discussion about their support of this bill and how important it was to have this supplemental screening in addition to some recommendations from my own personal history. So I was so thrilled to talk to her because she has done a fellowship in breast mammography and was very, very knowledgeable about this. So they were so supportive of this bill. And I wish the insurance companies could understand that $1,000 or $1,500 investment. Do you remember that testimony we had about that girl that $30 million potential in treating her? It makes no sense to me why insurance companies can't understand that if we invest in a small amount for further diagnostic treatment, that we would save money in the long run. And so I am disappointed in their opposition, and I'm disappointed that they objected to the original bill. But I will support this because it does make, I hope, a step in the right direction with awareness and some understanding. When you think about the fact that between 40 to 50% of women who have mammographies have dense breast tissue, which can hide a malignant lesion, it is kind of unconscionable to me that we would not be aggressive in finding that in order to benefit the patient and save the insurance company money in the long run. So I'm just kind of on my soapbox here for a minute, and I will support this. But I'm one of those people, and so I am going to pay out of pocket for some supplemental funding, and I mean supplemental screening, and I don't mind doing that. But for people that can't do that, we heard that in the testimony over and over again. I just wish there were more forward thinking with the insurance companies to understand about the savings that this was. And maybe with this small step in the right direction, we can build upon that in future legislative sessions. So thank you for letting me opine for a few minutes on this. And this is such a critical bill for women's health. And I will continue to advocate for women in this area. Thank you.
All right, thank you. And I didn't know you were a nurse, Representative Rosar. So do we have any further discussion at all on the bill?
Yes.
Yeah, all right, Representative Subak.
Thank you. I voted against the amendment because I think it takes the bill in the wrong direction. But obviously, I'll be supporting the bill. It is, as Representative Rosar said, a giant step in the right direction. It is my hope that when the sky doesn't fall as a result of doing this bill, as I think Representative Rosar and I both know that the sky isn't going to fall here, and that when savings start to be realized as a result, that perhaps Representative Rosar would be willing to work together with me or with one of my colleagues here on a bill that would expand this in the future. Sometimes baby steps are the best that we can get, and I think it's unfortunate that that's the case here. I will also just comment that I think it's unfortunate that so often it is when we are talking about women's health that we start talking about the baby steps. And healthcare costs more for women. That's been shown time and time again. Depending on which study you look at, the percentages do vary. But until we get serious about these sorts of issues, we as women will continue to pay more out of pocket for our health care, and that's just not right. And that is something that we have the power to change, and I hope this baby step moves us in the right direction. But I hope that when the sky, as I said, when the sky doesn't fall here, that we can then go a step further and expand this to all of the diagnostic tests that it should cover. Thank you.
Do we have any other discussion from committee members? I will say I'm glad to support this bill as amended. Being a father of 4 daughters and someone who lost a cousin at the age of 24 to breast cancer, this is definitely a step in the right direction. I'm proud to support the bill as amended. So without further discussion, the clerk will call the roll.
Moses,
Aye.
Rosar,
Yes.
Brooks, Summerfield, Dietrich, Gundrum, Vandermeer, Magnifici, Shutt, Sapek, Subek, Reamer, Vining, Anderson,
Yes.
Passes 14-0. All right. Moving on, we're going to exec Assembly Bill 398 next. So with that, I'll ask Ledge Council to please briefly summarize Assembly Bill 398.
Assembly Bill 398 creates an exception in the definition of employee for any individual who receives remuneration, a stipend, or compensation for being a participant in a clinical research trial for the purposes of workers' compensation, minimum wage law, and unemployment insurance.
All right. I'll entertain a second for passage of Assembly Bill 398. Representative Gundrum and Representative Summerfield. All right. With that, do we have any discussion on Assembly Bill 398? All right. Seeing none, I'll ask the clerk to take the roll.
Moses,
Aye.
Roser, Brooks, Summerfield, Dietrich, Gundrum, Vandermeer, Magnifici, Shutt, Sapek, Subek, Reamer,
No.
Vining, Anderson,
No.
Assembly Bill 398 passes by a vote of 10-4. Next, we'll be executing Assembly Bill 432. So I'll ask Ledge Council to please briefly summarize Assembly Bill 432.
Assembly Bill 432 allows an individual who is 17 years of age to be eligible for initial licensure as an EMS professional if the individual attends school, has parental consent, has a letter of endorsement from a sponsoring organization, and agrees to comply with applicable law, in addition to other non-age-related requirements for licensure or certification.
All right, I'll entertain a motion for passage of Assembly Bill 432. Representative Magnifici and Representative Brooks for the second. Thank you, Representative Brooks. Any further discussion? Representative Subek.
Thank you. I'm going to be voting against this bill. I think the testimony that we heard in committee and some of the questions were asked gave me a real sense of pause. The idea of a 17-year-old being the highest trained person on an ambulance and being solely responsible for making decisions, and I understand that they need to consult before they don't take somebody for transport, but they are also solely responsible for people in critical situations. We also heard testimony about the potential results of the trauma that a 17-year-old can experience. I mean, imagine 17-year-olds responding to gunshot wounds, to horrible domestic violence, and the impact that trauma has on them in the long haul. That gives me pause. I think about if I call an ambulance because something is critically wrong with me, I don't know that I would be confident in a 17-year-old being the person on the ambulance who is primarily, or in some cases, solely responsible for my care. I understand that we have a shortage, and I think there are real solutions that we should be looking to encourage individuals to get into the field, to figure out how we better staff those ambulances. I don't think that frankly child labor is the answer. I don't think that having 17-year-olds do a job that I don't think they're ready for. And, you know, we heard from a gentleman from the EMS Association who raised real concerns, and that's who I'm looking for to I mean, when I think about, maybe I'm being Pollyanna about it, but in this case, when I heard from him, I thought, okay, this isn't just me thinking I'm not comfortable with a 17-year-old. This is the professional saying they have grave concerns about it. I think we need to address our shortages. I don't think this is the solution that we are looking for, and I think it's a solution that puts patient health and safety at risk, and I'm not willing to do that, and that's why I'll be voting no.
All right, do we have any further discussion on Assembly Bill 432? Right, I will say as someone who actually worked in this field for a little bit, another lifetime ago, and talking to my local EMS services that support this bill, I am proud to bring this passage of this bill forward. So with that, I'll ask the clerk to call the roll on Assembly Bill 432. No. No.
We're not bringing it forward.
All right,
Passage of the bill.
passage of the bill, yep, on 432.
Moses,
Aye.
Rosa,
Yes.
Brooks. Summerfield. He's not bringing it forward. Dietrich. Gundrum. Vandermeer. Magnifici. Shutt. Sapek. Subek.
No.
Reamer.
No.
Vining. Anderson.
no,
All right, Assembly Bill 432 passes by a vote of 10-4. Moving on, we're going to exec Assembly Bill 687 next. So, Ledge Council, please briefly summarize Assembly Bill 687.
Assembly Bill 687 allows DHS to enter into value-based purchasing agreements with the manufacturer for the medical assistance program based on metrics to which DHS and the manufacturer agree in writing.
All right, I'll entertain a motion. Representative Shutt and Representative Dietrich. All right, do we have any discussion on Assembly Bill 687? All right, seeing none, the clerk will call the roll.
Moses.
Aye.
Rosar.
Yes.
Brooks. Summerfield. Dietrich. Gundrum. Vandermeer. Magnifici. Shutt. Sapek. Subek.
No.
Reamer.
Oh, I'm sorry, my bad,
Aye. Okay. Reamer.
Yes.
Vining. Anderson.
yes,
All right, Assembly Bill 687 passes on a unanimous vote of 14-0. All right, moving on to Assembly Bill 690. Ledge Council briefly summarize Assembly Bill 690.
Assembly Bill 690 allows certain medical facilities to employ or contract for the services of a nurse aide if the nurse aide meets 3 requirements: is in an instructional program, is employed part-time as a nurse's aide, home health aide, or hospice aide for fewer than 120 days, and has a preceptor.
All right, I'll entertain a motion for passage of Assembly Bill 690. Representative Rosar and Representative Brooks for the second. Thank you. Any further discussion on Assembly Bill 690? All right, seeing none, the clerk will call the roll.
Moses.
Aye.
Roser. Brooks. Summerfield. Dietrich. Gundrum. Vandermeer. Magnifici. Shutt. Sapek. Supek. Reamer.
Aye.
Vining. Anderson.
yes,
Assembly Bill 690 passes again by unanimous vote of 14-0. All right. Moving on to Assembly Bill 736, I'll ask the Ledge Council to briefly summarize Assembly Bill 736.
Assembly Bill 736 establishes a palliative care council. The bill sets requirements for membership on the council and requires the council to meet at least twice per year. The council must consult with and advise DHS on issues related to palliative care, but may not consult on issues of aid and dying. Additionally, DHS must establish a statewide palliative care consumer and professional information and education program and make available on its website information and resources regarding palliative care.
I'll entertain a motion for passage of Assembly Bill 736, Representative Sapek and Representative Rosar for the second. Any discussion on Assembly Bill 736? Representative Rosar.
I think I need a screwdriver here to hold up my mic. Thank you, Mr. Chairman. I so appreciate this bill, and I hate to repeat, I'm a nurse. I'm so proud to be a nurse, okay? You guys do not understand what wonderful profession nursing is. And I saw this played out so much in my profession. If we had gotten some patients in palliative care before they had to go to hospice, it would have been so much better for the patient and their family. And I just appreciate the testimony that we had so much, explaining to people what the difference between palliative care and hospice are. Palliative care gives patients a chance to address end-of-life measures. It helps them to have an increased quality of life. Doesn't mean you're dying. Heart failure is the thing that comes to my mind. Heart failure is a progressive disease. Eventually, the heart becomes too pooped to pump. And because of that, the patients die. There's an article called Too Pooped to Pump, and I used that when I was a nurse educator. So you get somebody with heart failure in palliative care, they're able to prepare for the inevitable when that happens. And so I would like, and y'all, I'm going to explain to you all that because you have to understand why that happens. So I appreciate Representative Snyder and Senator James bringing this bill forward. I look forward to hearing about how the council is going to help educate people about palliative care and how they are really going to increase the quality of life for people that are on that trajectory before they have to go into hospice and deal with the last 30 to 60, 90 days of their lives. So as a healthcare professional, it's just such a wonderful thing, and I look forward to really good things coming out of this council, and thank you all for the support of this bill.
All right. I will remind members that we are under time constraints in this room as well, but I would echo a lot of what Representative Rosar said about the bill as well. Do we have any further discussion on Assembly Bill 736? Time constraint? No. All right. Seeing none, the clerk will call the roll.
Moses.
Aye.
Rosar.
A very strong aye.
Brooks. Summerfield. Dietrich. Gundrum. Vandermeer. Magnifici. Shutt. Sapek. Supek.
Aye.
Reamer.
Aye.
Vining. Anderson.
Yes.
All right. Assembly Bill 736 passes unanimously again, 14-0. So we'll keep this going. We'll move on to Assembly Bill 914. If Ledge Council can please summarize the bill.
Assembly Bill 914 allows the school to obtain and provide or administer a short-acting bronchodilator to a student with a prescription or a person in respiratory distress.
All right. I'll entertain a motion for passage of 914. So moved. All right. Representative Subek.
Second.
And Representative Reamer. Look at that. We even got some support on that side this time. That's good. And do we have any discussion on Assembly Bill 914? Another great Representative Schneider bill. So with that, I'll have the clerk call the roll.
Moses.
Aye.
Rosar.
Aye.
Brooks.
Aye.
Summerfield. Dietrich. Gundrum. Vandermeer. Magnifici. Shutt. Sapek. Supek.
Aye.
Reamer.
Aye.
Vining. Anderson.
Yes.
Assembly Bill 914 passes unanimously again by a vote of 14-0. Great end to the executive session today. Without objection, we'll recess the executive session in case members would obviously like to record their vote. And then also, I'll ask for unanimous consent to carry over the roll from the public hearing. Without objection, we'll carry over the roll from the public hearing or the executive session to the public hearing. All right. Do we have any questions or comments from committee members?
I have a comment.
Yep, go ahead.
I think you're doing a great job.
I am trying to roll along. I'm trying to get support. We're moving.
I just have a quick question. Is
Yes,
Representative Rosa a nurse?
I was going to answer your question and say, yes, I'm a chiropractor, for those of you who didn't know that as well. But a few kind of housekeeping things before we move into the public hearing for today. We are under time constraints for this room, so I'm going to try and let everybody talk that wants to. So in order to do so, we're going to try and impose like a time limit of about 4 minutes. I'll probably be a little loose on that, but certainly if you can state things succinctly and briefly, that would be very much appreciated. So with that, we are going to move on into the public hearing portion. So we have 6 bills on our agenda for public hearing, the first of which is Assembly Bill 954. So I'd like to invite the author of the bill, Representative Callahan, and I believe the senator is not with you today. So this will be a great opportunity to hit some really hard questions on Representative. Thank you for being here today.
I was a little worried I was going to be late, Mr. Chairman. I took the stairs, but being young, it's good to know that my heart is not too pooped to pump.
Yeah, that is very good.
All right, Chairman Moses and members of the committee, thank you for holding a public hearing on Assembly Bill 954. Wisconsin, like many other states across the country, is facing a physician shortage. According to our State Department of Health Services, 33 out of the 72 counties have officially designated as a health professional shortage area, meaning the shortage of primary care physicians in these areas has led to the inability to meet the needs of their residents. As our elderly population continues to grow and life expectancy increases, the situation will only worsen. By 2030, the country as a whole will face a shortage of over 120,000 physicians. That year, nearly 40% of American physicians will reach retirement age. To combat our own state shortage, Wisconsin will need to acquire 2,000 more physicians. So what can we do to recruit more physicians to our state and help solve this issue? We need to eliminate barriers to employment for already fully licensed physicians. Right now, Wisconsin has a redundant residency requirement. In order to practice in Wisconsin, fully licensed physicians who have been trained in a foreign country must complete a residency in the United States. This, paired with a cap on the number of available residencies they must compete for with U.S. and international medical students, limits fully licensed foreign-trained doctors from even attempting to get past this barrier. Assembly Bill 954 is crucial to our healthcare workforce because it will eliminate this redundant residency requirement. These doctors have already gone through the training in their home country, sometimes having practiced for many years. Importantly, these doctors must have an offer of employment in Wisconsin to pass by the requirement. Thank you again for this opportunity to testify in support of Assembly Bill 954. I'd be happy to answer any questions committee members may have.
All right, thank you, Representative Callahan. Do we have any questions for the author of the bill? I've got one. Representative Callahan, how is this different than the bill that was introduced last session?
Yeah, so last session you may have recalled that there was a list of countries. There were some concerns with the medical organizations in our state as well as some colleagues. We have eliminated that list of countries from the piece of legislation. And we also added in one example, having an offer of an employment in Wisconsin is one of the requirements that needs to be met. So for a physician from an international country to come and practice, they need to have an offer of employment already kind of pending. We also work to ensure that the applicant is in good standing with the medical licensing or regulatory agency of his or her country. They also need to practice as a physician 5 years after completing their residency in their home country before able to use this program to their benefit.
And how many other states have passed similar legislation to this?
So currently, Tennessee is the closest piece of legislation to similar to this legislation here in front of you today. But in the states of Utah, Virginia, Kentucky, and Florida, they have something similar that are expected to pass relatively shortly. And I know that there's some folks here to testify that will have a little bit more in-depth information on what other states look like when it comes to international physicians.
All right, thank you. Do we have any other questions from committee members? All right, Representative Subek.
I did not see this in the bill, but it is possible that I missed it, so that's why I asked. Does somebody need to have practiced recently to qualify? So, for example, if somebody was licensed in another country but hasn't practiced in 10 years, perhaps they came here and weren't practicing, whatever their circumstance might be, is there any sort of recency requirement that would ensure that they had practiced within some period of time or any sort of?
Yes, there is. Actually, as you were asking the question, I was skimming my notes. I know that there's a group of folks that will be up to testify. I'm going to defer to them just because I can't find it here, but I know that there is a requirement that they need to practice recently. I think it's 10 years, and it could be even 5.
Okay, and I don't know if Ledge Council could.
Oh,
I was like scanning through the thing looking for it and couldn't find it, but maybe she could point us to where that is.
Yeah, bottom of page 4, line 23, the applicant has been in good standing with the medical licensing or regulatory agency of his or her country of practice for the 5 years preceding the individual's application and does not have any pending disciplinary action before the medical licensing or regulatory agency. So yes, 5 years preceding application.
But so they have to be in good standing with them. I guess that I didn't read that as they had to have actually practiced medicine in the last 5 years. Is there something in terms of being in good standing in the definition that I'm missing?
Whether the applicant is in good standing in their country of practice would depend on the laws of that country.
So the fact that they have to be in good standing doesn't mean that they necessarily have practiced medicine in the last 5 years?
That's possible.
Okay. Thank you.
Any question? Oh, Representative Brooks. I almost forgot you there.
Oh, that's right. Just one quick question. When you talk about they have to have an offer of employment, is there any conditions to they have to work under someone for a period of time? So, and the reason I bring that up is I could be a pain management clinic, offer up I'm trying to think of the term here, and they could open up their own clinic without any supervision, or a surgery center. If I'm selling a franchise, like I'm thinking of Advent or something like that, or there's no requirement that they have to work under anybody, just that they have an offer of employment.
Correct. They would need an offer of employment to use the program, but I'm not entirely. I mean, this would apply to physicians and physician assistants. I think in your scenario, I'm not a medical doctor or anything, so I think the lines may be a little different. I don't think that a pain manager would be. I think save that question for some of the folks that testify. They might be able to better answer that question. I'm not entirely sure, Representative.
All right, thank you.
All right. Any other questions for the bill author from committee members? Seeing none, looks like you're free to go, Representative
All
Callahan.
right, thank you. On to the next committee. Hopefully not too pooped to pump.
Very good. Use the elevator. With that, the next up to testifying in favor is Chris Jones with Cicero Activism. Welcome, Chris.
Thank you. Thank you, Chairman, honorable committee members. My name, and thanks for giving me the opportunity to support Assembly Bill 954, authored by Representative Callahan and Senator Tomczyk. My name is Chris Jones. I'm a senior fellow and vice president for healthcare at Cicero Action, a nonprofit that advocates for entrepreneurial solutions to public policy problems across the country. Representative Callahan did an excellent job, I think, of the overview. I won't read through. I would say very similar things. in respect to time. I do think, would want to double down on a couple of things he said. I think between last session and this session, there was discussion with the medical providers. And if you think about that offer of employment from a provider out of the gate, they are responsible then for that physician. And they are responsible for the medical malpractice, the liability related to that physician. So that, and when you look at the majority of the providers who are in Wisconsin, there is a physician-led component to it. And so that is their reputation on the line as it relates to doing this work. I think to the other questions that come up, I think they've been really good questions that you've raised. As it relates to what's the period of time that exists that the individual needed to practice, some states have said 2 years. And so I think there's different things that could be considered that way. To Representative Brooks' question, physicians and or PAs, the supervision model that Tennessee is using is very similar to the supervision model that exists between a physician and a PA currently. So you have a lot of flexibility within the way this model bill is currently put out there, and you could put additional safeguards should you so want to. So with that, I'd be open to any questions.
All right, thank you for your testimony. I'll start with Representative Dietrich.
Thank you, Mr. Chair. Thank you for being here, Mr. Chisora. Since you suggested it, do you think it needs more safeguards added to it?
Chairman Representative Dietrich, I would not necessarily say that. I would really work with the provider community because, again, they are the ones who are sponsoring that physician or that PA, and they are going to do what they think is best. And this is not something that's going to happen overnight as well. So I think there is, I would be hesitant to adding more guardrails and be evaluating the program as it goes to identify. Because again, the medical examining board still has the authority to revoke that license just like they would with any other physician.
Thank you. Thank you, Mr. Chair.
All right, Representative Subek.
You seem to have some knowledge of how this has worked in other states, so I'm hoping you can answer this. If not, feel free to let me know that. But I'm wondering about qualifying employers, sort of hearkening a bit to what Representative Brooks was asking about. Have other states defined what a qualifying employer would be that might help in ways that might help clarify that offer of employment?
Yeah, Representative Subek, I think the one that probably makes the most sense is Tennessee. Mm-hmm. And what Tennessee did was limit it to those providers who have residency programs already. Okay. So there's already that culture that exists. I would say, as you look at this, I mean, I think there's been a lot of great bills I've heard this morning in executive committee as it relates to trying to augment the workforce in healthcare, and whether it's EMS, whether it's nursing. I think this is one for physicians, and then I think, but with that, you also have to look at where those residency programs are, and if you're also trying to solve a rural physician gap, which I think Representative Callahan mentioned as part of his health professional shortage areas, would talk to the providers out there as well and make sure that you're not exacerbating the issue as it relates to finding qualified physicians to come and work in the state of Wisconsin. Prior to being with Cicero Action, I was the Commissioner for Health and Human Services for North Dakota, but prior to that, I spent 20 years with Catholic Health Initiatives, which is now Common Spirit, and at one point had responsibility for about 150 to 200 rural physicians across Minnesota and North Dakota. And so know how difficult it is to recruit, how difficult it is to retain, because if you think about these hospitals are often the first line of, they are the emergency room, and they likely only have one physician on duty. And that can create some risks for that hospital should that physician either get sick or have a family emergency. That hospital can't operate unless they are operating an emergency room. So I think when you're thinking about the considerations and the safeguards, I'd really encourage you to work with the rural providers as well.
And Tennessee and some of the other states that have done this, how long ballpark have they had this in place?
Tennessee went live January 1st of this year.
Okay. Have any of the other states been doing it longer? What I'm curious about is if we've seen any outcomes, and it may just be too soon and that's okay, but if we've seen any outcomes as far as, is this actually successful in particularly some of those recruitment areas in rural areas? Do we see folks with international licenses wanting to practice in those areas?
Representative Subak, there isn't so much data on that so far, but I would add that nationally, I didn't look at where Wisconsin is, but 25 to 30% of all physicians are international medical grads now. And when you look at their quality as it relates to domestically trained physicians, in some, depending on the specialty, I mean, all of them are very close, but when you look at primary care, internal medicine, IMG, international medical grads have slightly better quality scores than domestically trained. Now, I'm not saying domestically trained physicians aren't any good, but there has been a fair amount of data done that way.
Sure. Thank you very much.
All right. Do we have any other questions from the committee? Seeing none, thank you for your testimony, Chris.
Thank you for the opportunity.
That is all I had for testimony on that, on Assembly Bill 954. So registrations, I got registering in favor, Senator Corey Tomczyk. Registering in favor, Rachel Vivaldi with WMC. RJ Perlott, registering in favor with Wisconsin Academy of Physician Assistants. Rebecca Hogan, registering in favor with Cicero. And Connie Scholze registering against but not speaking. So with that, that concludes the public hearing on Assembly Bill 954. We are moving on to Assembly Bill 418. So I'll invite the author of the bill, Representative Rosar, who's a nurse, by the way.
I think I'm already on, so we'll just leave it on. So thank you, Chair Moses and members of the Assembly Committee on Health, Aging, and Long-Term Care for holding this hearing on AB 418 relating to healthy aging grants and making an appropriation. As stated in the Legislative Reference Bureau analysis, this bill provides $378,000 each fiscal year of this fiscal biennium to a private nonprofit entity to support evidence-based health promotion programs to support healthy aging. The population entering long-term care facilities is growing as our population in Wisconsin is aging. One leading factor for individuals entering a long-term care facility is injury from a fall. I have seen so many elderly people go downhill after a fall. It's just very, very sad what happens when an elderly person falls. They break their hip, they get a subdural hematoma, they have some kind of an injury, and many times that's the straw that breaks the camel's back for their longevity. According to the CDC, Wisconsin currently has the highest mortality rate due to falls of any state in the U.S. AB 418 provides funding for best practice strategies to prevent falls, manage chronic conditions, and increase physical activity to reduce costs and improve wellness. Furthermore, it will provide balance and strength training, which helps reduce an older adult's fall risk. Back to that prevention piece. Prevention in this case is worth more than a pound of cure. Based on available information from CMS, fall-related health costs in Wisconsin are estimated at about $1 billion a year. At a time that spending is tight, utilizing resources for healthy aging grants leads to lower costs over time that prevents unplanned out-of-pocket expenses for older adults. Additionally, falls occupy the time of emergency services, leading some departments with insufficient funding and capacity. I'll just give an example of this. My mother, who lived in Virginia at the time, was a very high fall risk, and she would fall in her apartment, and nobody in the long-term care facility that she was in, because of the independent living that was available, could help her get up. So they would have to call EMS or the fire department to lift her up, and even though she would not need to be taken to the emergency room because she hadn't sustained any injury, it still was a time-consuming thing for them to have to come and help her up. So I appreciate your kind consideration and support of this bill. I think this bill can help our aging population grow safer and healthier while reducing the burden on Medicaid in Wisconsin. I'm happy to answer any questions that you may have about this piece of legislation. And you're acting as chair right now?
I
Okay.
guess I am.
I'm thinking I'm not up there and Chair Moses is gone,
Yeah, so any questions for Representative Rosar? Any questions? Oh, you can come up and take the
Well,
gavel.
thank you. I appreciate that.
Yeah, Nurse Rosar. Representative Nurse Rosar, I'm sorry. Take your time. I don't want you to poop out on the way up here. All right, next up we have Mike Stanley with the Oshkosh Fire Department. And there you are, young lady.
Good morning, honorable members of the committee. I am very appreciative of the opportunity to take a few moments of your time to come and testify in support of AB 418. My name is Mike Stanley. I'm the fire chief for the city of Oshkosh and also the immediate past president of the Wisconsin State Fire Chiefs Association. Thanks to Representative Rosar for authoring this bill and championing it for our state. I think it's a very progressive and visionary bill to move us forward as a state. That, as she mentioned, that we are leading the nation in falls deaths. That people that are falling are receiving a death sentence in this state. And as she mentioned, it is a very discernible progression of events, that when we see them in the pre-hospital environment, these patients that have fallen down, and started falling, and initially they may just need to be picked back up. And that creates a tremendous burden on our public safety model in fire and EMS in all the communities across Wisconsin, whether they're career, combination, or volunteer. We have to dedicate many hours, many resources, many dollars to picking these people up, which that in of itself is problematic. But like I said, we see this progression of events. Once we start seeing them in the home beginning to fall, those falls will get progressively worse. They will be more injurious, and they will many times lead to their death. That is a very predictable timeline, that from when that person starts falling, they're probably going to die within a year. And I don't think that any of us want Wisconsin to be a leader in this regard. I think this bill is an opportunity for us to be a leader in the nation, to start addressing the fact that falls are a statewide problem, and we can start to develop and implement statewide solutions to this. Falls are preventable. These deaths, these injuries, these negative impacts, not only to the elderly person that's falling, but to their families, to their loved ones, that we can prevent that. And this is an outstanding first step to making that happen. As an aside, I'm also here today. I was down in the first floor rotunda. We're demonstrating some different devices that can be used to assist people that have fallen, to lift them up other than somebody's just mechanical strength and using their own body. And having some more discussions and engaging about this crisis we have in this state around falls. So if given the opportunity for you or staff to come down, I'd love to have some further discussion. So I would implore you, as my colleagues will give you more on statistics and excellent testimony here, but I would implore you to support this bill, that make Wisconsin not only a better place to live, but a place for our residents to live better. But again, I thank you very much for your time. I know you've got a packed agenda and busy days ahead of you, so I'd be happy to entertain any questions or discussion at this time.
So thank you, Mike. We appreciate you making the effort to get here, and I look forward to coming down and seeing your lifts down in the rotunda. Representative Brooks has a question.
Just real quick, do you know off the top of your head, I know this is a critical problem in a number of my communities where 50% of the calls or more are just for aiding people that have fallen. And not just in their residence, but going to CBRFs and other types of facilities. And then the local emergency services aren't able to recoup those costs. So it's a tremendous liability and cost, on the fire departments, EMS, et cetera. Do you know approximately percentage of calls that you respond to are just for falls?
Yeah, absolutely. And that's excellent points and questions, Representative Brooks. So it is, across the state, we are seeing a very disproportionate number of our responses, our incidents being to falls. For example, in the city of Oshkosh, that it is upwards of 20% of our total call volume, heart attacks, fires, car accidents, 20% of that total call volume is for falls. And we're seeing that, anywhere from that 20 to 50% of the agency's responses, like you referenced, is the norm. And you are exactly correct that many of those falls, not only do they happen in private residence, but they happen in some type of senior living facility where someone is paying to be in that facility and they are not providing that service to pick them back up. Many times they have no touch policies of staff of the facility can't touch them. The person has to lay there, compromising their dignity, many times in their own waste, waiting for fire and EMS to arrive on scene, pick them back up. And you are correct, it transfers 100% of the liability to that responding agency. If they should drop that person or they become injured. So now one of our responders that is lifting that person up injures a shoulder, a knee, a back, and has to be on workers' compensation disability for the rest of their lives, that burden has shifted locally into the state rather than to the for-profit entity. We look at the long-scale long-term outcomes. Now, if I'm getting up 3 times in the middle of the night as a volunteer to respond to pick somebody up, and now I'm tired and can't perform in my full-time profession, or I hurt myself, I tweak my back, my knee, and now I can't go to work and make a living, why would I volunteer my services? So it has this ripple effect into recruitment and retention, which is also such a struggle in this state as well. So it really does have far-reaching implications that you're pointing out.
Just a quick follow-up, because I just asked Representative Rosar, Chairman Rosar, 378,000 is such a specific number here in the Capitol, and it is such a huge problem to all the taxpayers across the state. This is a good first step, but if you could provide the committee, and I'm not going to take your time today, but if you and your colleagues could provide us some other fixes to this problem for everyone across the state, because it is a 20 to 50% use of your efforts, that would be greatly appreciated. This is a good first step. But clearly, this is a huge crisis, and we need to address it. So any suggestions you have that you can provide to the committee would be great.
Absolutely, and thank you for acknowledging that. That as far as the specificity of the dollar amounts, that one of my colleagues from the Wisconsin Institute for Healthy Aging is going to speak to how they arrived at that number. Yeah. So I'll let her address that. But as far as larger scale, your other opportunities that you're mentioning, you also should be seeing some legislation from Representative Paul Mary around some other solutions about some changes in requirements around those facilities to disallow them from having those no-touch policies, to require them to have trained staff, to train residents on fall recovery and fall prevention. So I think you're going to continue to see additional legislation introduced, and very, very happy to provide this committee with some other solutions, that I've seen locally, statewide, and around the country. So thank you for that opportunity. I'll make sure to follow up with you, Representative Brooks.
Thank you very much. It was very an informative testimony. I appreciate it. Representative Vining.
Thank you, Madam Chair. Off the top of your head, I realize I'm asking you this on the spot. 2 questions. Do you have a sense for the gender breakdown of the people that you respond to calls for?
Absolutely, that particularly in Oshkosh, we took a pretty deep dive of, who is falling, why are they falling, and women edge out men on the falls. Some that you can look at nationally, women tend to live longer than men, so they're going to reach older ages, et cetera. But locally and pretty much statewide, that we're seeing more females fall than males. I'm sorry, I think it was a 2-part question.
Yep, I haven't asked you the second part, but that's what I was thinking, because I think some of the perimenopause, menopause research is pointing to treating earlier because falling comes later. So that's why I asked. Thanks. The second question is the ballpark percentage of head injuries that end up accompanying the fall.
Pretty high, and that is many times the leading cause of death. That they're falling down. Really, there's two progressions. You're going to fall down, hit your head, get a traumatic brain injury, and that's going to be what leads to your demise. The other thing is the broken hip. The broken hip renders them immobile. They end up, so there's a kind of a rule of thumb statistic. 50% of people that fall and break their hip will contract pneumonia. 50% of those people that contract pneumonia will die. So, you're either going to die from pneumonia, from being bedridden because of your lack of mobility, or because of that traumatic brain injury that you're talking about.
Yeah, that's helpful. Thank you.
Thank you. Are there any other questions from the committee? Okay, hearing none, thank you very much. We appreciate you making the effort to come. Next, we have speaking in favor of the bill, Mary Laube from the UW Hospitals and Clinic Authority. So, Mary, welcome. And you may begin when you're ready.
Thank you. And I do have copies if someone wants copies.
Go ahead whenever you're ready.
Okay. There you go. Thank you. Good morning, everyone. Dear Chairperson Moses and members of the committee, thank you for allowing me to join you this morning to express our support for Assembly Bill 418 related to healthy aging grants. My name is Mary Laube. I'm proud to serve as the Adult Injury Prevention Coordinator for UW Health's Level 1 Adult Trauma Center. I'm here today representing the interests of our patients, especially those who suffer falls and receive care at our health system and at health systems throughout Wisconsin. In our view, the fairly modest investment of $378,000 annually that you are considering would be money well spent. Our Level 1 Trauma Center cares for patients with the most severe injuries from across the state, and like other trauma centers throughout the United States, we find many patients are adults with injuries that are the result of a fall. In fact, our trauma center patient census has increased each year for the past 5 years, as the patient population treated for injuries from falling represents an ever greater percentage of patients overall. Between 2018 and 2021, the total adult trauma patient population increased by 16%. Patients being treated for injuries from falls increased by 35%. In 2022, 60% of the adult trauma patients had injuries from falling. Furthermore, Wisconsin continually reports the highest rates of deaths from falls in the United States. These are alarming statistics, but we're committed to improving the outlook for patients. In 2021, the UW Hospitals and Clinics Authority Board, the governing body for UW Health, endorsed preventing falls in older adults as a healthcare priority. The following year, the board approved fall prevention as a community health improvement strategy. As a result of their endorsement, we were able to steer resources toward this goal, and while we are proud of our efforts to date, we know this is not a problem a single healthcare system can solve. Communities across Wisconsin need resources to support local nonprofit experts in healthy aging and adult wellness and exercise, along with their partners in EMS and healthcare to create effective prevention practices and interventions. In our case, we convened a work group of UW Health practitioners and staff, including physicians, surgeons, geriatricians, physical therapists, and staff from trauma, surgery, family medicine, and geriatrics, to join forces with our community partners, such as the Wisconsin Institute for Healthy Aging, EMS, and others, to reduce injuries and deaths from falls. This combined effort allowed us to benefit from the interventions that were working and to share our expertise with one another. With this cooperative effort we just launched last year, we expect to see positive results in future years. We applaud the authors of AB 418, Representative Rosar and Senator Fine, for their leadership and for recognizing the need for organized fall prevention efforts administered by DHS. Please advance AB 418 from the committee at your earliest convenience with a vote of yes. Thank you for your consideration. I would be happy to try to answer any questions from the committee members. And you will see you have some colorful graphs attached to this testimony.
Thank you very much, May, for your testimony. Do we have any questions? Any questions? Hearing none. Thank you very much for your
Thank you.
testimony and coming down today. Next up, we have Janet Zander with Greater Wisconsin Agency on Aging Resources, and then that'll be followed by Jill Renkin. And that, I think, are the only, one more. Followed by David Bowen. Hello, sir. You have the floor whenever you're ready. Just make sure your mic's on.
Thank you. Good morning, members of the committee. My name is Janet Zander. I do the advocacy and public policy work for the Greater Wisconsin Agency on Aging Resources. I also support the advocacy and policy work of the Wisconsin Aging Advocacy Network. I come to you today with an interesting background, 16 years as a volunteer emergency medical responder. I've been a nursing home social worker, and I was an Aging and Disability Resource Center director who was in charge of delivering these evidence-based health promotion programs locally to citizens in my community. So I've seen the very best, and I've seen the very worst. As a nursing home social worker, I can attest to the impact that hip fractures have on a frail older adult. That was often that slippery slope that led to a whole bunch of debilitating diseases and death. Over the next decade and a half, we all know that our population of older adults is going to continue to grow, and with that growth in population will be an increase in the demand for health and long-term care services and supports. These programs, however, have demonstrated that we can improve our health and well-being as we age and reduce our need for health and long-term care services. That's the kind of recipe we need to protect our own personal budgets, our state budget, but also our health and well-being and independence so that we can, in fact, continue to live in our homes and communities. GWAR, the Greater Wisconsin Agency on Aging Resources, and WAN support AB 418, directing the $378,000 to a nonprofit entity. In doing so, we'll be able to expand the number of local health, the number of local health promotion program providers. We can sustain the infrastructure that we need to support them. I'm well aware of the training of program volunteers that this takes, the licensing that these programs take, and we have a very efficient system here in Wisconsin if we can sustain that system. It will also ensure that these programs are available to everyone in the state. Chronic conditions and falls are not exclusive to urban, rural, suburban, right? These are everywhere for everyone, and in fact for people of all ages. But we know that falls and chronic conditions are debilitating and costly. You've heard the statistics about falls, you've heard the statistics about chronic health conditions. This state investment would help us to reduce falls and the associated injury and costs, and help people to better manage their own chronic conditions and increase physical activity. This will reduce costs, improve wellness, and reduce the burden here in the state. We appreciate the interest and efforts of policymakers to improve the health and well-being of older Wisconsinites and of all Wisconsinites as we age. We look forward to continuing to work with you on policies that improve the life of older adults. Thank you for your consideration of my comments on AB 418, and I'm happy to answer any questions.
All right. Thank you for your testimony. Do we have any questions from the committee? I guess they've all been covered. Thank you for your testimony.
Thank you, Chairman Moses.
All right, next up, we have Jill Rankin speaking in favor with the Wisconsin Institute for Healthy Aging. And then on deck, we have David Bowen with ARP, I assume. Yep.
Good morning, and thank you very much for the opportunity to speak to you today in support of AB 418. I also want to acknowledge and thank Representative Rosar, as well as Senators Fine and Quinn, for introducing this Healthy Aging Grants legislation. My name is Jill Rankin. I am the Executive Director for the Wisconsin Institute for Healthy Aging. We are a nonprofit organization working to improve the health and well-being of older people and people in general as they age here in Wisconsin. While AB 418 would support much of our work, I do want to focus today on falls prevention. So as you've heard some statistics earlier, Wisconsin does have the highest rate of deadly falls among older adults in the nation. 1,635 older people died due to a fall here in Wisconsin in 2021. Each year, more than 1 in 4 older adults has a fall. 20% of those result in an injury, as you heard Mike talk about, like a hip fracture or a traumatic brain injury, making falls the #1 cause of injuries in older adults. More than 43,000 older people went to the emergency department due to a fall in 2021 at an average cost of $1,788 per visit, and over 10,000 were hospitalized at an average cost of $20,615 per hospitalization. And of course, behind those numbers are people. Somebody's mother or father, somebody's grandparent, people who fell and were injured, people who fell and were unable to get up, people who now fear falling again, so much so that they stop doing the things they love, stop doing the things that they normally do, and become isolated, which causes further health concerns. Community members become patients, family members become caregivers. Just one fall can have a big impact on many. And as you've heard from Mike Stanley, falls also have serious implications for public safety and their capacity to meet community needs. Wisconsin EMS providers responded to over 130,000 older adult falls, making it the top injury response in 2022. That's 25,000 more than in 2019. Nearly 1 in 5 ambulance runs were for older adult falls in 2022, and the majority of those are which that happened in the home. But the good news is that while falls are common, they're not inevitable, and they're not an inevitable part of aging. We do know what factors induce a fall, and with state investment in fall prevention, we can help people reduce their falls risk. AB 418 would do 2 critical things to prevent falls. #1, it would provide funding to the Wisconsin Department of Health Services to maintain the Falls Free Wisconsin Initiative, which is a statewide movement launched with 1-year funding from the Administration for Community Living to raise awareness of and motivate older adults and their families to reduce their risk of a fall. And it would provide backbone support to the multidisciplinary Falls Free Wisconsin Coalition. Specifically, state investment would, #1, fund community grants to provide resources for local fall prevention efforts. We did give 10 grants totaling $70,000 this past year to fund these local efforts. It would also raise awareness of falls risk and prevention strategies among older adults, their families, and caregivers, and provide resources to reduce their risk. It would expand access to programs such as Stepping On that are researched and proven to reduce falls. And then finally, it will expand the Falls Free Wisconsin Coalition, bringing professionals from aging, public safety, and healthcare together, all to develop and spread best practices for fall prevention in communities throughout the state. As I mentioned, initial funding to launch the Falls Free Wisconsin did come from a short-term grant from the Federal Administration for Community Living this past year. We see Healthy Aging grants as a means to sustain the effort here in Wisconsin over the coming 2 years, as we continue to work to secure more long-term funding from other sources. At the same time, we look forward to the opportunity also to demonstrate our effectiveness as good stewards of these resources. Today, 1 in 4 Wisconsinites is 60 or older. By 2040, it will be 1 in 3. Now is the time to engage older adults, their families, their caregivers to make knowledge of fall prevention strategies commonplace and have the resources available. I urge you to vote in favor of AB 418 to make that goal a reality. Thank you very much.
All right, thank you. Do we have any questions from committee members? Oh, thank you.
Oh, and I do want to address that. There was a question, I think, Rep. Brooks, you had a question about the budget. And yes, so how we came up with that number is by our previous grant that we had received from the Administration for Community Living this last year. We modeled our budget based off of what we did this past year. So it includes personnel, a health educator that does do all the work for the fall prevention and training for our partners throughout the state that do these programs and effectiveness, as well as funding to our local partners to be able to do localized fall prevention efforts. Thanks.
Look at that. Representative Brooks doesn't even have to ask a question. And it is my understanding this was funded in previous budgets as well up until this session.
Yes,
I believe
a few years ago for 1 year. Yep.
So, all right. With that, and this is the last testimony speaking that I've got. So, Representative or former Representative David Bowen representing AARP of Wisconsin.
Thank you, Mr. Chair, and thank you, members of the committee. I have good news and bad news about what happens when you leave the legislature. The good news is that things become a little bit lighter, and you're welcome in everybody's office. The bad news is that you age a little bit slower, but you can't tell looking at my beard. So, I really hope all of you are well. I want to thank you guys for allowing me to testify in support of AB 418 on behalf of our state director at AARP Wisconsin, Martha Cranley, our state director. This bill directs DHS to allocate $378,000 as a grant to a Wisconsin nonprofit like the Wisconsin Institute for Healthy Aging that coordinates a network of local providers, including aging offices, ADRCs, health systems, senior centers, public health offices, physical activity centers, and others leading actions related to healthy aging. AARP Wisconsin is excited to see actions that include implementing evidence-based health promotion programs to support healthy aging, a statewide clearinghouse on evidence-based falls, injury, disease prevention, self-management, and health promotion programs providing training and technical management, health promotion programs providing, as I said, training and technical assistance to the staff of county departments, administering agencies and others providing services to aging populations and collecting and disseminating information on falls injury, disease prevention, healthy promotion, and healthy aging populations. According to the CDC, every year more than 25% of adults 65 and older fall. And falling once doubles a person's chances of falling again. Sometimes a fall causes serious injury such as a broken bone. At least 300,000 older adults are hospitalized due to hip fractures. Wisconsin has the highest rate of deadly falls in the country. 1 in 4 older adults has a fall every year. Wisconsin county level falls data will also show an estimate of $1 billion is spent annually in Wisconsin for Medicaid and out-of-pocket costs due to falls-related health care. Older adults' falls have significantly impact on our public safety systems, EMS, fire, and ED as well. For instance, even Oshkosh Fire Department, 21% of their calls were for older adult falls. Furthermore, the stats are very clear on this. 95% of older adults have one chronic condition, 80% have 2 or more, 90% of the nation's healthcare costs are for chronic conditions. In Wisconsin, the direct costs associated to Medicaid are about $1.15 billion annually. AARP Wisconsin stands with our advocating partners for Wisconsin's aging population, including our partners at the Greater Wisconsin Agency on Aging Resources, Inc., in support of this bill, authored by Representative Rosar and Senator Fain. We appreciate the leadership and focus of our target population that at many times experience the challenges of living healthy, free of injury from falls. Communities from all over Wisconsin would have a chance to benefit from these grants that help support local efforts to minimize the negative impacts of older adults in our communities being prevented from true independence. Thank you all for the opportunity to provide input on this common sense legislation, and we at AARP look forward to working with more legislators to promote options to support our aging population. We urge all members of this committee and the full legislature to support AB 418, signed by my state director, Martha Cranley. Thank you guys so much, and if any questions.
All right. Do we have any questions for David from the committee? I will say, I'm never a fan of huge expansions and stuff, but David, you touched on a lot of the things that as a business owner, I think about return on investment and what the cost is, to this versus letting people fall in the long-term health ramifications. Because for those of you that don't know, I'm a chiropractor for the last 20 years. And yeah, I know. And
did you guys know this? Did you guys know this?
Yeah, this is new news, like Rosar's a nurse. But see how many times I can work that into the committee. But, one of the big things I see in the detriment of people's health, especially in the later years, is these slip and falls and balance issues that they have. And having an 85-year-old mom that lives by herself, that's one of the concerns we have with her all the time. So when I saw that it was funded in the budget prior, and then when the EMS services and the fire is in support of it because the cost that it is to them as well. But David, you hit a lot on the statistics of it in your testimony there. So for me, this is a bill. That's why I wanted to give it a hearing. So do we have any other questions from committee at all? With that, thank you for your testimony.
Thank you. And please provide service to the Cowboys fans. They're hurting right now, and they could use your services.
On to the 49ers.
Have a good day, guys.
All right, that concludes our public testimony for Assembly Bill 418. I have some registrations here. I have George Kletch with the Wisconsin State Fire Chiefs registering in favor. I have Connie Scholze with UW Health and UW School of Medicine registering in favor. And then I have H.J. Waka with Department of Health Services registering for informational purposes. All right, we are now moving on to Assembly Bill 830. So I would invite Representative Gustafson and Senator Rachel Cabral Guevara. I almost complimented you again, Senator, by calling you representative, but good to see you over on this side.
I'll take either. I'm honored to have both.
It's always entertaining when you're in the room. So with that,
The energy.
you're going to get that from me all session too, just so you know.
It's okay. It's okay. Keep you all on your toes.
Yes.
Thank you for having us here today and allowing us to testify.
Alrighty. Well, thank you, Chairman Moses and esteemed members of the Assembly Committee on Health, Aging, and Long-Term Care for scheduling this public hearing and providing me the opportunity to testify in favor of AB 830. I also want to express my gratitude for my colleague, Senator Rachel Cabral Guevara, for being my Senate lead on this. Medical assistants who primarily work in hospital settings provide adjunctive services to both physicians and chiropractors. These adjunctive services include the taking and preparation of preliminary patient history and providing physiotherapy treatment. Currently, a medical assistant must obtain a chiropractic technician certification from the Wisconsin Chiropractic Examining Board. This bill eliminates the requirement that the medical assistants obtain a redundant chiropractic technician certification in order to provide these adjunctive services at the direction of a chiropractor, provided that they were trained by an educational program accredited by the National Commission for Certifying Agencies. So simple enough, I urge you to support AB 830 today. Your careful attention to this matter is greatly appreciated, and I trust that you can see the impact of what this legislation could do for our state. I will turn it over here to my colleague.
Thank you very much. So just to briefly summarize what Representative Gustafson has said here. In essence, this bill allows chiropractors who currently cannot delegate basic services to medical assistants unless these medical assistants have both the chiropractic technician certification, as well as the training by the National Commission of the Certifying Agencies. So in essence, this bill will allow chiropractors to delegate to medical assistants, with these medical assistants being properly trained, number one, as well as properly supervised by those chiropractors to do some basic sort of services, such as the idea that we have discussed is rooming services. So may this be patient history, may this be blood pressures, may this be applying cold packs or hot packs, may this be minimal laser techniques for inflammation. These are basic skills. Medical assistants, I've worked with many of them. They're amazing individuals that do have educations from the tech colleges to get these certifications, and they do these things in essence already. I thought this was very interesting, the support that was behind this bill. It is from both chiropractic groups here in the state of Wisconsin, and sometimes they don't always see eye to eye, but came together on this amazing legislation here. We also have the Wisconsin Neuropathic Doctors Association, as well as the Medical College of Wisconsin. And so you can see that these folks feel that these MAs are qualified to do these things and already do these. In other settings, not necessarily with chiropractic. We'll have folks here testifying today, but again, I want to make this very clear. These medical assistants will be properly trained on these things. Many of these techniques and services they're already doing, just not delegated from chiropractors. And number two, that there is always supervision that will go on with these chiropractors. So it is important for them and for their license to make sure that these individuals are properly trained so that there will be no issues or concerns.
All right, thank you for your testimony. And do we have any questions from committee members on this? Representative Brooks.
So just one quick question. The American Physical Therapy Association had a recommended amendment, just to I guess a clarification. Have you seen that?
I have, and there will be folks behind me that will speak on that.
All right, perfect. Thank you.
Yes.
Any other questions from committee members?
Do we have a chiropractor present?
Yeah. I was going to avoid that, but I've actually over the years employed a couple of dental assistants, which we've had to have take the CT course and stuff. So I assume this bill obviously won't cover them because there's enough differences. Would that be the case?
Can we clarify with Ledge Council on that? I
mean, where we've utilized them for like rooming services, patient histories, basic
and
stuff.
that is the same kind of skills that would be asked of the MAs that they're already trained on, but allowing delegation from Chiro. But I wanted, Ledge Council, if you could clarify.
Just personal experience, we've gone through the redundancy of having them take the CT program just to make sure they're on the same page for sure, but go ahead.
The bill addresses medical assistants and chiropractic technicians.
But not dental.
Yeah, it gets kind of broad.
Medical assistants, not medical assistants.
Do we have any other questions? And I do have someone lined up to answer questions if the authors aren't able to take them as well. But other than that, we don't have any testimony after you, Senator, so.
Well, I do have another bill following up here, 955, so I'll just hang out and wait.
All right.
Thank you very much for allowing us to testify on this today.
Thank you.
I have questions about my neck pain, but I'll ask you later.
Yeah, that's off, yeah.
Is that for a chiro or for the nurse practitioner?
It sounds more like a chiropractic complaint from being on the health committee.
Unless you're being on the neck has to do with your colleagues.
Oh, yeah.
I'm hoping my low back doesn't get sore from this committee. I'm hoping it's not a 6-hour one today, so. And then, John, from the Wisconsin Chiropractic Association, did you want to field a question on the PT's information only? Because I know we had discussed it, and I think you got probably the best understanding of what that does. So next up, we have John Murray, representing the Wisconsin Chiropractic Association.
Green's on, green's off. All right.
So,
Representative Brooks. Committee members, thank you. I was not planning on testifying, but I'm here to answer any questions, and be careful about putting a former politician in front of a microphone. There's a lot of history on this, and I won't bore you with this, but I do think it's important, and I just want to follow up on Ledge Council. So the original delegation bill was actually authored by the former chair, of the Health Committee, and it was 2017 Wisconsin Act 180. And what that did was allowed licensed healthcare professionals, anybody that held a license, and there's a whole list in the statute, such as a dental therapist, to answer your question, Mr. Chairman. Anybody that had a license in the state of Wisconsin as a licensed healthcare professional, and there's a definition in statute, could now be delegated these adjunctive services with the understanding there'd be direct on-site supervision, and they had the training. And the idea was to give chiropractors and hospital systems more flexibility with their staffing, okay? And so what we realized afterwards, which you always realize after you write a bill, that medical assistants, the professional, not the program, are not licensed in the state of Wisconsin. They exist under this kind of, I'm going to say gray area, but kind of under the Medical Practice Act as essentially professionals that provide services to physicians, okay? So after we realized the bill, and then the examining board actually put some additional language in the administrative code that had the same safeguards of direct on-site supervision. If, say, Chairman Moses hires a dental assistant, he has to provide direct on-site supervision. They have to have the training, or ultimately it is the chiropractor's license that's on the line. And I think that's the point that I want to make, that this is not just hire these people, they have the training, and then the chiropractor goes out to lunch. They have to be on-site, and they have to ensure that they have the training. Otherwise, a complaint could be filed with the chiropractic examining board. So I think that's a pretty big safeguard. And that safeguard is one of the things that we're talking about, making sure the language is strong enough in either statute or administrative code for the medical assistants that we now want to bring into this. It's primarily hospital systems. As you can see, Medical College of Wisconsin supports this. They staff their spine center. Gunderson has a spine center. Aurora has a spine center, and they want to be able to staff those spine centers with both MAs and chiropractic technicians. But right now they're limited in terms of if they have an MA staffing them that day, they can't even delegate a patient history, which is really silly because it's well within their training. And so that's the primary thing that this addresses. We were made aware of a concern by the Wisconsin Physical Therapy, or the AAP, Wisconsin chapter, what they're called now. And we're working with them to come up with a clarifying amendment. And we hope to have that to the committee before you take an exec. They registered, I think, for information only, and we want to meet them at their needs. We certainly want to be respectful of their concerns. But I do want to reiterate that these MAs already get a training, an accredited program through a national accrediting entity. And many times they have way more training than CT. Not to diminish the CT training, but many times this is actually almost an associate level degree that the MAs get. And then, but it gives them the flexibility to be able to say, if they just want the MA to do basic pacing history, and they want to be able to room the patient, as the senator said, if they want to get them trained on some additional things, they could. But I understand that a lot of the hospital-based MAs don't do physiotherapy right now, that it's more cost-effective for them to have a PT or a PT assistant do that. But again, it's about giving those systems the flexibility to decide what types of providers they want to hire and what type of training they want to get with adequate safeguards. Does that answer your question, Representative Brooks? Yeah. Well, long answer, like I said, forewarned you, so.
All right, and just to clarify, John, what is the requirement for CT in the state of Wisconsin to be a chiropractic technician?
So they have to, it's a 12-hour baseline program. It's written out in actually, I'm going to put my glasses on because I'm aging as well. It's actually laid out in Chiro 10. It's actually very, very prescriptive, I warned you, administrative code, but it lays out the number of hours that they need, and it's essentially a 12-hour program as a kind of a prerequisite, and then what they do is they give them the option if they want to get them trained on these modalities. This is like laser stim or e-stim, exercise rehab. Not all clinics in Wisconsin want to offer laser. They're kind of expensive machines, and so it doesn't require them to get trained on all of them, but they can. And if they do, there's an hour requirement. So, and we offer this program. CSW offers this program. Moraine Park offers this program. There's plenty of people offering this program, but the baseline program is 12 hours. The one thing I do want to comment on is the experience with these CTs is they generally do not have college, they are not generally college degree. They don't go to college and then become a CT. It is generally people that have either an associate degree or even less than that. So you're talking about people that may not have a fundamental understanding of anatomy, Some groups are better than others, but the point is, this training is very valuable for this group. These are people that actually do put hands on patients, and so we think the training program is very adequate, and there is actually a hearing tomorrow at the examining board to try to diminish those requirements, and we are against that. But it's all laid out in Cairo 10. We think it's a good training standard for these. And again, I'll reiterate this. The chiropractor has to be on-site supervision, and they have to guarantee that they have the training for that type of service, and the quality and manner order is their license. And I think that's the ultimate hook that you got to remember. It's the same thing if they're now going to delegate to an MA.
All right, thank you for that. Do we have any other questions for John from the committee? Thank you for the clarification.
Hopefully we'll have a clarifying amendment and you can support this bill. Thank you for your time.
And then that was all we had for public, those speaking on this bill, registering for information purposes only, and it was mentioned by John as well, Sue Griffin from the American Physical Therapy Association, who has been great to work with in coming up with something that works for multiple professions and making sure that we're doing a good job. So she registered for information only, and then Peter Welch registering in favor as well, representing the Naturopathic Doctors Association. So that concludes the public testimony for Assembly Bill 830. We're moving on to Assembly Bill 955. So I'll invite, and I don't think Representative Gobin is quite here yet. She's in another committee. So Senator RCG, if you can come up and talk, the floor is yours. And then I think she'll be joining you shortly, so.
I know this bill is pretty important to her. Do we want to pass over one
Well,
and come back to her?
I thought of that, but you were in the room, so if you want to wait, if that's okay, we.
I think let's do that if we can, because I know this is pretty.
The problem I have is it's the only bill in Representative Sortwell's committee, and Representative Sortwell is the next author of the next bill. So
Okay, well, I can testify for this bill. Thank you very much for allowing me to come back up here and testify on another bill here today. Currently, there are vaccines that have been proven their worth, such as tetanus, MMR. We have measles, mumps, rubella listed there, even hepatitis vaccines, polio. In essence, let me stick away from my script here. In essence, what this bill is saying is if somebody is on a transplant list and they are looking to get a transplant, they should not be refused to be placed on this transplant list if they have not received certain vaccines, particularly such as the COVID vaccine or the influenza vaccine. We will have folks here to testify that they have been denied to be placed on the list when it comes to these immunizations. Now, as a nurse myself, I do support some vaccinations. A majority of them, by the way, but some I have found that the effectiveness, the efficiency of these particular vaccinations have been questioned, particularly in the last few years. And so in essence, what this bill would do would prohibit people from not being allowed to be on that list if they have not received the particular COVID or the influenza vaccine. As I mentioned, tetanus, MMR, polio vaccines, these have been around for quite a long time. These we have shown over and over again their effectiveness. So this bill does not eliminate all vaccinations, just the ones that vary year to year. Just the ones that kind of predict into the future what are these viruses going to look like, and the ones that have lower percentages of effectiveness and efficiency that we have noticed over the last few years. This bill also does allow folks that have had positive titers for things such as COVID to be utilized and acknowledged when it comes to taking them into consideration if they're placed on this transplant list or not. We have seen effectiveness in titers. This says that somebody has been exposed to this particular illness. This also says that these individuals have had natural response and immunity to these particular illnesses, and that does provide the body with defense against these diseases. And Miss Joy came running on in here.
Welcome, Representative Goldman. So she left all the tough questions for you. So.
Oh, that's so fantastic. So at this point, we'll take questions. Just to summarize, I just gave a brief overview of this bill and how certain vaccines would be allowed to be placed for individuals on the transplant list, such as MMR, tetanus.
Okay, I don't know that my testimony is a lot different than that, so I don't know if we just do want to go into questions, and I do apologize for being late. I was just, had a hearing on cotton candy, so.
Questions?
right.
I guess we're open for questions
We're
then.
open.
Do we have
You have the
questions
testimony.
from the committee members? And we do have people testifying after you as well, so. Nothing? Brooks, nothing? Oh. Well, yeah, right. Looks like we don't have any questions at all. So Representative Gobin, you ran up here for, yeah.
All right, great.
So the photo.
I just ask folks to really be open to listening to the testimony today from families that are directly impacted by this. And when we talk about people's rights and so forth, how is this impacting? So just be open to testimony today. Thank you.
Oh, yeah, Representative Murphy.
So, thank you, Mr. Chairman, and thank you for bringing this bill. The only question I had was, in your testimony, Senator, you said, I'm trying to remember, I'll have to paraphrase what you said, but something about I'm okay with certain vaccines, but not others. And I'm trying to understand, what does the law say now about transplants and patients having these? I mean, is this more like trying to get out in front of this problem, or is it, or is this, this is the problem? Does it exist right now?
This is a problem because people have been removed or not put on the list.
Okay.
Because of this issue.
Okay.
I do believe in Representative Gobin's pile here, and I do believe that this is going to be submitted to you folks also, requirements from a couple facilities that actually indicate that if you do not have these particular vaccinations, that you will not be placed upon this list. So I would like that to be submitted also. Are we correct that it has been submitted? If you look at that. So this is actually currently happening. I personally...
So you can give us a list of different things that they're requiring.
And they will, yes. I guess I would ask Ledge Council, I do not, from my understanding, think that this is a particular law. I think this is a particular preference from facilities, what they choose. But I don't think there's any particular statute that says you have to have the COVID shot or you have to have the flu shot.
Yeah.
So does the bill eliminate a transplantor, whoever's doing that work? Does it preclude them from having any vaccination requirements? Does it take, would say you can't have any, or is it just certain ones?
It's just certain ones.
Okay.
And
I'm sorry,
I
I
had a
could have
list
probably
on
read that,
here
but I've
of
been
the
flying around
particular-
this building today. And
Yeah, it's been a wild day for us all, let me tell you.
Where do we have the particular?
So in essence, this bill is not going to say you have to have this one, this one, and this one, and this one. It's saying you don't have to have this one or this one. So in essence, you don't have to have the COVID, you don't have to have the influenza. And again, I do support some immunizations. They have been tried, they have been true. But when it comes to variable immunizations, such as the influenza vaccine, who you predict a couple years in advance, put it together, and then administer that, and you're not right on target all the time, and you look at the effectiveness and the efficiencies of these particular immunizations, those are the ones that I'm questioning here.
And sort of what I'm trying to get to here is, if there are certain vaccinations which they could require, but then certain ones that they couldn't, and the ability to differentiate, how are you differentiating?
The bill covers vaccines designated for emergency use, operates through the transfer of genetic material, is dosed on an annual schedule, or is for the prevention of a disease against which the individual already shows antibody protection. So it's a limited, and this was something that we had to work on this, because there are vaccines that the senator felt we should have. This is very expensive to have a transplant, and there are things that should be there. So this is a specific, because it's more specific. So yes, it's not all.
All right. Good. I think that takes care of my questions. Thank you.
Does this bill include people that want to donate an organ as well, not just the recipient?
Yes.
Representative Subek had a question.
Thank you. You indicated that some facilities or some healthcare providers require certain vaccines. Why do you think they have those requirements?
Are you asking myself?
But you're the
Yes,
one who
yes, yes.
indicated, but either of you could feel free to answer.
I-
I'm curious because I heard that healthcare providers require this. I guess that I'm wondering what your thoughts are as to why they would put such a requirement in place.
Well, I think that vaccines do hold a purpose, right? They prevent certain diseases from occurring. Now, the question is, again, the efficiency or the effectiveness of those particular vaccines. I'm not questioning MMR. I'm not questioning tetanus vaccinations. I'm not questioning polio. What I am questioning, though, is the flu shot, where we have seen in years the effectiveness of it being 20 or 30%. I'm questioning a COVID shot where you're getting 4, 5, 6 doses of this medication immunization, yet people are still coming down with COVID. These are the ones that I am questioning. But I'm not going to sit here and debate MMR, measles, mumps, and rubella. I'm not going to sit here and question tetanus. I see the effectiveness of these. They don't have to be administered every single year. They don't have to be changing of the dose, not dosing, but the formula of this. They have been tried and they have been shown to be effective.
They have a lot of long-term data on that. But imagine yourself being in you're sick. Your organs aren't functioning. And then to consider that you're going to put in a chemical into your body, it can cause a lot of fear. And so the vaccinations that have long-term data, they should be supported. But there are some that don't have that long-term data. And that's where this is kind of coming in.
All right. I suspect, and I think that there are folks testifying later who can probably answer this from their perspective as well. But I suspect the reason that they require those vaccinations is because that increases the success rate of the organ transplant. But I'll let them perhaps speak to whether that's right or not.
We have looked into that, and the data was not there to show that was an increased success rate.
All right, well, I'll be interested to hear from them as well. I did also hear you say, Senator, that you talked about, and both of you, I think, talked about those longer-term vaccinations, MMR and some others, and said you don't question those, so you're okay with them on the list. But we have heard people in testimony in this committee question the effectiveness and risks associated with the MMR vaccine and all sorts of things. I happen to disagree with those people and believe that we should require those vaccines. But it sounds like you're saying because you don't believe this, we shouldn't require it. Should we, whose judgment should we use here? Should we be using the medical professionals, or should we be substituting the judgment of any individual, whether they are a legislator? And I do know that you have medical training, but again, transplant isn't your training. Whose judgment should we be using here? Medical providers or any one of us as an individual?
I would say look at the data, look at the numbers, and look at the efficiency or the effectiveness of particular vaccinations. There are a lot of people that after COVID are very fearful of certain immunizations, and I think that if you choose not to get a particular immunization for whatever reason, if it has not been proven to be highly effective, that they should have those rights, not to particularly obtain an immunization that is a new or an experimental immunization, something that has not been around for a considerable amount of time and has been proven to be effective, whereas we have seen some that have had higher effectiveness than others. Now, I'm not going to go into debates about past legislation or individuals and how they feel about that. I'm coming from what I feel is my medical background in regards to the effectiveness of vaccines, and I just question variable formulas of vaccines that are changed every few years.
Sure. So 2 final questions. What is an appropriate amount of time to consider something having been around long enough to be proven? What is that magic number? We're legislating for the long term. So at what point should we sunset this when it reaches some number of years? How does that work? And 2, what level of effectiveness are you looking for? Whether that's in prevention or other health improvements, what is it that you are looking for specifically? What data would get you, what data is it that would get a vaccine added to or subtracted from your list? So,
yeah. Those are fair questions.
Do you want to comment to either of those?
I don't know that I can comment specifically to that. I think that would be something we could look into. But traditional vaccine development, from research to clinical testing, marketing, it takes 10 to 18 years. That's the normal process, and that's not what has happened. So there isn't the data that you're asking for to say if something is really effective, if it will help that person getting the transplant to have a more successful outcome. That data isn't there.
Thank you.
Does this bill prevent a transplant patient from getting a vaccine or immunization?
No, it does not.
So they would have the choice to make the healthcare decision for themselves on this then?
When it came to the list that she provided, the specific list that she provided, yes.
Representative Brooks has a question.
We went from
Thank
no
you.
questions to a lot of questions.
yeah.
Thanks, Representative Murphy.
You open them up. That's okay. That's okay.
Just to clarify, I like the bill, obviously. In one section, it says we can't solely, on the basis of an individual's vaccination status or disability, do any of the following. So it can be a consideration, but you can't remove somebody from a list or just solely based on a vaccination, correct?
Correct.
Okay. And then in section 6, it says no person may discriminate against an individual in a matter relating to. So walk me through that. So the way I read the bill, it's my decision, as the chairman said, to get the vaccine or not. You just can't arbitrarily not put me on the list based on that one condition. That doesn't mean a hospital couldn't take it into consideration as a series of things, or does it? Because it's kind of says you can't discriminate based on that. Walk me through what your thinking is there.
You can't discriminate based on, did you get the vaccine? No, you're off the list.
Okay. Could it be a factor in the list of,
I think they would need other factors. They're
Right.
going to look at other factors, not that.
like, somebody like myself, overweight, high blood pressure?
Well, those are
those are things, that you can, well, I'm just saying.
Are you feeling convicted
Yeah,
about
I'm doing my
something,
own
Representative?
self-diagnosis because it's easy, it's me. So you can go down that list, but they can't do it because I didn't get the COVID shot.
Right.
Okay, that's what I thought. Thank you.
All right, do we have any, Representative Subek?
Just one more question that came up because of what Representative Brooks asked. We're tag teaming here on the question. So the word solely, does that mean that that vaccination status could be used in terms of some sort of scoring or prioritization, but not whether you're on the list altogether? Or would it actually say that couldn't, would it actually not? And maybe it's a Ledge Council question.
I think that would be a
I
Ledge
think
Council
you have
question.
two
'cause
provisions here.
I
one
would
on-
say
yeah.
no, they can't use it at all. But let's see what Ledge Council.
Let me take a quick look at the existing statute, and I'll follow up in just a minute.
Thank you. Thank you.
Do we have, in the meantime, any questions from committee members? Brooks? No. Representative Brooks?
Pressure. Come on.
Representative Murphy? No. Let's keep going down the list.
I'd just like to say, as someone who sees patients on a regular basis, no matter where you stand or where your beliefs are in regards to COVID, there are a lot of people out there that this has invoked a lot of fear into them. It has invoked a lot of fear into them. And wherever you stand politically, quite often, that is where your beliefs stand when it comes to this COVID vaccination. And I feel very sad for the people that choose not to get this particular vaccination for whatever reason. They're already having life struggles. They're on a transplant list for a reason. And for them to simply be denied over an immunization is disheartening to me. They already have enough struggles that they are dealing with. And, I mean, I hear your concern about the statistics and so forth, but again, truly look at some of these statistics with this COVID vaccine. I've had patients that have received numerous COVID vaccines and still have ended up in the hospital. This vaccine is not preventing, all COVID illnesses and hospitalizations, and it just makes me very sad that individuals are being turned away or taken off of this list simply because of this and the fear that many people have from the outcomes of COVID. Yeah. And we'll see in the future the great negative impacts. May it become patient fear, patients' level of screening and prevention that has declined, patients' overall fear of immunizations and decline overall on them. COVID has been a tragedy within the world of healthcare here in the United States. So thank you for at least listening to our
Senator,
bill here
you can
today.
stop stalling because we've got an answer from Ledge Council.
Are you cutting me off again?
Well,
Are you
keep
cutting me off
talking.
again and booting
What
me?
I learned a long time ago in sales is the more you talk, you lose the
I
sale.
know,
So.
but it's one thing that I think
why I'm
about all the
quiet.
time, and how sad I get about all of this. So I will be booted, Chair.
Yes, so under the bill, one of the things that cannot happen solely on the basis of the vaccination status is placing an individual on an organ transplant waiting list at a lower priority position than the position at which the individual would have been placed if the individual did not have that vaccination status. So you cannot be at a lower place, a lower priority position on the waiting list solely based on the vaccination status.
Does that help you, Representative?
I think so. The word solely is where I'm just getting a little bit hung up, because if you take it into consideration in conjunction with other factors. I mean, I'm trying to make sure we're clear on what the bill does, and I'm not sure I'm 100% clear based on that.
How does it, and I don't mean to confuse things more, but like Ledge Council, how does it compare to like someone who is on, been a chronic user of drugs and alcohol on the transplant list?
I've been thinking about that myself, because last session we did have a bill about transplants and active users and active individuals that were still consuming alcohol without having treatment options in place. Currently you have to have well, I don't know if it's current anymore, but there was a time frame where you had to be clean and not abusing substances before you were on the transplant list. Now last session we actually had a bill about that on the floor, I do believe, unless my mind's slipping, but that would say that was actually discrimination if they were not placed on the list, even if they were active users still. So I was thinking that same thing.
I thought of that right away because I have a personal situation. A friend of mine who had a daughter, well, she's still alive, thank God, has a daughter that's in her mid-20s that had huge, horrible alcohol addiction problems and needed a liver transplant. And she had gotten bumped like 6 months longer than had she not, because she had to be clean in order to receive it.
Yeah.
And this was about a year ago. She's doing awesome now. Honestly, you look at her, you don't even realize that she had it, but she was near death and needed this transplant because of her drug and alcohol use, was not placed a priority on it.
There was a bill on that last session. I don't remember the outcomes of that, though. I know it was in assembly.
And it was signed into law, my clerk tells me, so.
So currently, could Ledge Council clarify on this? If you are an active user of substances, you can be placed on the transplant list and not discriminated against, but you can be discriminated against for COVID and immunization towards influenza?
So the section of the law that is changed by this bill primarily also addresses discrimination on the basis of an individual's disability. I would need to do a little more research to know if disability could include alcohol use.
I'm pretty sure.
No, that's kind of a separate, they're saying that there was already passed the alcohol and drug. That's a separate issue
So they
from
don't
this.
currently have,
They want to know, currently, can you be discriminated against because of drugs and alcohol?
under current law, it would depend on whether the use of drugs and alcohol is considered a disability.
Okay.
And I can't tell that from this section.
And my clerk just confirmed what you said. Kind of a weird thing. I'm going to overrule the germaneness of the chair on this, because we're kind of going
I
off
was
into a
beginning to
separate.
wonder,
We're going
Mr. Chair.
a little bit separate. So, do we have any questions that are germane to the immunization status for transplant patients?
Oh, I think that is
All right.
significant.
Thank you. Back to the cotton candy representative.
Thank you.
With that, next up to testify in favor, speaking in favor, is Anita Day.
Good afternoon, ladies and gentlemen. I guess it's afternoon now. Thank you for everybody for listening to this Bill 955. My name's Anita Day. I live in Milton, Wisconsin, and I'm here to represent my son, Jamie. And if you don't mind, I'm going to read, because Jamie was normal and active child until he reached the age of 8.5, till he was diagnosed with diabetes, type 1. I was devastated. I saw the outcome that we were going to face. I saw it before any of it ever happened. We were told then, in 1987, that we would have a cure within 10 years. That never happened. This gave us hope, though, that we could look down the road and see an end to this disease and not the slow death sentence that we were really facing. I've since realized that a cure for this is never going to happen, and there is no money in a cure. Jamie isn't here today because he gets very tired and wears out easily, and sitting here for any length of time would not be good for him. He is hooked up to a machine nightly as it drains his energy. Jamie is a college graduate with a bachelor's degree in IT. He's a single dad raising 2 wonderful boys. 15 years ago, Jamie was determined to get into shape so he would be here for his boys. He worked out 2 and 3 hours a day and lost over 75 pounds. He watched everything he ate, and having no salt had enabled him to stabilize his kidney function longer than what the doctors ever expected. He stayed at around 33% range for several years and then gradually dropped into the 20s and continued to decline 1 and 2% every year. He's currently at 6%. Jamie has to watch everything he eats and counts all of his carbs so he's able to adjust his insulin. He also needs to watch all sodium intake to help protect his kidney function, what little is left. Diabetes, although it's considered a treatable disease, it's a very cruel disease. Diabetes eats away at your internal organs, kidneys, heart, lungs, brain, pancreas, just to name the major ones. Diabetes had taken a toll on his body. His kidneys are down to 6%, as I said. Jamie has had multiple laser surgeries in both eyes to blast hundreds of floaters to try and save some of his sight. While he was in his 30s, both lenses were replaced because of cataracts. He has lost his sight completely in one eye and has tunnel vision in the other. Jamie has been on peritoneal dialysis at home for the last 18 months. Peritoneal dialysis creates its own problems in patients. It causes extreme constipation, needing daily use of all of these items: stool softeners, Miralax, lactulose, which is a prescription, prune juice. This is not a fun time, and it usually is a daily thing. He is limited on what he can do and length of time he can be gone due to the strict regimen of being hooked up to the machine every single day. This has also caused depression and anxiety for him from not thinking about being allowed to get on the transplant list or getting a transplant and the inevitable result, to not trusting the medical system to be honest with him. When the vaccine first came out, he did a lot of research. He found that it could cause kidney damage, something he obviously didn't want to add to his declining kidney failure. We were told 10 years ago by UW-Madison that once he reached just below 20%, they would put him on the list for a kidney pancreas transplant. Now they won't put him on because of because he refuses to get the fast-tracked and untested COVID vaccine. The recommendations by UW Hospital now states that patients must be vaccinated, and it's also recommending that everyone in the same house be vaccinated. On August 15th, 2023, we went to Froedtert Hospital in Milwaukee, where they've removed the vaccine mandate and state that it would be best if he took it, but not in their mandatory regimen. We went through all the preliminary 6.5 hours of tests and questioning by the transplant team, and they still have not put him on the list. COVID hit in 2020 and has systematically changed the healthcare system in our country, and not for the good. Healthcare has lost 25% of the workforce since the COVID vaccine rollout. As a mom, I would do anything to protect my children. I'd give a kidney if they allowed me. I'd blood transfusion, whatever it took. It doesn't matter their age. We will always worry over our children and do whatever it takes to save the life of their child. Any good parent would do that. If you've ever dealt with a catastrophic illness, you will understand how rigorous and daunting it can be. Every waking hour is consumed with dealing with all treatments and restrictions involved. We could go to a different state for a transplant. Texas, Louisiana, Florida, to name some, all allow it, but his insurance will not pay for it. I don't know about you, but I don't have an extra $1 million laying around. My cousin had a kidney transplant in 2009, and he was out of pocket around $100,000, and his total bill was well over $1 million. So I don't have that extra laying around. Discrimination comes in many forms: religious, sex, race. It goes on and on. The discrimination against people who have chosen, for whatever their personal reason, to not take a vaccine, especially one that has been rushed through and not properly tested, is an atrocity. It is an individual's right to choose what is put into his or her body. I never thought that anything like this would ever have to be discussed or even voted on. I'm angry that all of this has to be done. There is no research, only opinions whether immunity of COVID through the vaccine has helped anybody after transplant. There is no information. The last available research was 2022. Doctors take the Hippocratic Oath to become a doctor. It refers to ethics of their chosen profession, and it boils down to, I will do no harm. I want them to honor their oath that they swore to. I wish I had the magic words to say just the right thing to convince everyone how important this is, and to reach deep down into their conscience and their heart and do the right thing. This country was founded on individuals' rights to many freedoms, and we need those rights to protect those freedoms. If the common sense solution is not passed, our freedom of choice is lost. By voting to pass Bill 955, you can restore the rights of my son Jamie and the many thousands of other patients facing the same fate. Thank you.
All right, committee members, do we have any questions? Seeing none, thank you for your testimony.
Thank you.
All right, next up we have Heather Allen representing the Wisconsin United for Freedom, along with Aaron Runk. Did you want to come up? Yeah.
Good afternoon, everyone. So I want to thank Chairman Moses as well as committee members and co-sponsors of Assembly 955 for holding this public hearing today. My name is Heather Allen, and this is Erin Runk, and we are here representing Wisconsin United for Freedom, Wisconsin's largest health freedom organization. For those of you who are not familiar with our organization, we were founded in 2019 when a bill was introduced which would have removed one of our vaccine exemptions for daycare and K through 12 students here in Wisconsin. We were moms and dads who decided to jump into politics because we realized that our children's futures were at stake. You often see us here at the Capitol fighting for our right to medical freedom. We want to express our support for AB 955 as it relates to prohibiting discrimination in organ transplantation and donation on the basis of an individual's vaccination status. There have been several heartbreaking incidences, like Anita and her son Jamie, as she testified, reported in which patients were denied a much-needed organ transplant, or incidences of individuals being removed from the transplant waiting list entirely due to their vaccination status, not just for COVID-19. Or incidences of not being added to the transplant list based on their vaccination status. This can have a life or death impact. We agree with legislation that would stop medical establishments from enforcing their overreaching and life-threatening policies that discriminate against those on the organ transplant waiting list based on their vaccine status. Vaccination should be a decision that patients make with their trusted healthcare providers, and those in need of an organ transplant are no exception. They should not lose their bodily autonomy by opting out of a medical procedure that carries both known and unknown risks just because they are in need of an organ. I did want to mention that while this bill would cover some vaccines, our stance as Wisconsin United for Freedom is that it should cover all vaccines. Every single vaccine on the recommended schedule, whether it's an annual vaccine or not, carries risk. And we do not believe discrimination should be allowed to occur just because it's one vaccine over the other. Thank you for your time.
All right. Do we have any questions from committee members for Heather? All right. I had a couple questions, and I appreciate you guys being succinct and prompt, obviously, on this. Last session, when these bills came up, this next series of three are kind of ones that we had from COVID and stuff, and I remember there being a lot of people here for testimony. So I know when we reached out, or you guys had reached out to testify on these, and we had a time constraint on the room, and we have already had some long hearings. Can you describe how many people showed up to testify in favor of these bills last time?
The last time was at 2020, right, Representative Moses? It was an 8-hour-long hearing, and we had, oh my goodness, hundreds, and it was standing room only for some time during that portion of that day, and it lasted over 8 hours.
And,
so, yeah.
And how many members do you guys have in your organization?
We're over 50,000 within our community.
So I certainly appreciate, and I hope the committee appreciates, that there's a lot of support, and we don't have 50,000 people testifying today on this. Because I remember last time, because I was on the health committee sitting through the testimony, hearing all the stories and all the personal impact of these bills that it had on people. So I appreciate you two keeping it on point today as well. So do we have any other questions from the committee? With that, thank you for your testimony. And like I said earlier, that is all we've got for people speaking on that Assembly Bill 9. Oh, yep, speaking against, sorry about that. Speaking against, Melissa Roberts with the UW Health, UW School of Medicine and Public Health. Sorry about that, Melissa. I was moving along nicely. So as soon as you are ready, the floor is yours. Yep, just get the sergeants.
Good afternoon, everyone. Thank you so much for taking the time to hear us today and have this hearing. I'd like to start off and say the purpose of this is to articulate our opposition to Assembly Bill 955 related to a transplant patient's vaccination status. I'm Melissa Roberts, current Executive Director of the UW Health Transplant Center, and I'm a current quality consultant for UNOS, the United Network for Organ Sharing. I've been doing that for about 10 years. I'm a registered nurse, and more importantly, I'm a transplant recipient of a dual organ transplant for 20 years. I just celebrated 20 years in October. I feel my personal experience combined with my professional expertise gained through 25 years of work in this field of organ donation and transplant qualify me to speak knowledgeably about the potential downsides of this legislation. It's important to begin with some facts specific to the UW Health Transplant Center, which is a source of great pride for our academic medical center. For more than 55 years, the UW Health Transplant Center has led the nation in serving adult and pediatric transplant patients, as well as living and deceased organ donors who provide the gift of life. We transplant more than 500 patients every year on average, and we provide more than 85% of all transplant care in the state of Wisconsin. Our history is rich with innovations, including the discovery of the UW solution, which was the first successful cold storage fluid developed to effectively flush and maintain organs, donated organs during transport to the recipient. The solution is still used all over the globe today. Another example of our innovation is the development of a drug called Cellcept, a widely used anti-rejection medication that helps transplant recipients live longer. But we aren't resting on our laurels. Our work continues to focus on new medications and techniques that improve the outcomes of patients. One of the ways we secure excellent outcomes for our transplant patients is through a comprehensive evaluation process. Our process, like all other transplant centers in the country, is meant to identify potential areas of patient risk and intervene to decrease that risk before the transplant, thereby ensuring the patient is ready to receive a donation and that they have the best chance of a successful outcome. For example, our patients are screened for cancers, latent heart and lung issues, psychosocial support, and support of their home environment. That evaluation also includes a review of vaccines that the patient has received, such as childhood vaccines, yearly vaccines, and those known to cause specific infections that are difficult to treat in transplant recipients. In the majority of cases, we require select vaccines to help prevent dangerous infections after transplant. Any transplant surgeon will tell you that vaccines are most effective when given before the transplant and the receipt of the immunosuppressant medications. Those immunosuppressant medications weaken the body's response to a vaccine because they prevent the creation of antibodies against that specific illness. Transplant recipients who develop infections tend to become much more ill due to their body's inability to fight off infection. As evidence of that fact, I can point to our experience with COVID patients before the vaccine became available. We saw the rate of death was more than 10 times higher among transplant recipients hospitalized with COVID versus patients without transplants that had COVID-19. That's an alarming statistic we don't want to repeat, but under the terms of AB 955, patients would be able to decline certain vaccines like the COVID vaccine, potentially increasing their risk of a negative outcome after the transplant. For these reasons, we ask you to oppose AB 955. Thank you for your consideration, and I am more than happy to take any questions you might have.
Melissa, thank you for your testimony. We do have some questions. I'll start. I've got one. Who determines this criteria? I mean, is there a board of directors, or who sets, what criteria is on this application or whatever for organ transplant by the UW?
Yes, the criteria and our selection criteria are established by our multidisciplinary selection committee. That includes social workers, nurses, physicians, medical physicians, and surgeons. It includes many times psychologists, pharmacists, dietitians. So we really look at the comprehensive picture that the patient presents.
And obviously, you're looking at good clinical data. So how often do you meet and revise this data? I mean, is it an annual thing or is it ongoing? How does that work?
It is ongoing, and at least annually we make sure to update the policy to reflect that it has had a careful review. But for example, when COVID began, we talked to the centers in Italy that had the experience prior to us. We were on national calls to try to get a sense of everyone's experience with it.
Do you ever look at data on outcomes on patients that have had the full protocol of immunizations, vaccines, versus those that have not? Because it kind of sounds like you don't necessarily do transplants on people that have not had all the mandated vaccines.
We do. There are occasions, for example, we do all sorts of transplants. We do heart, lung, pancreas, liver, kidney. And so there are patients that are too critically ill they don't have the time to be vaccinated. And so there are certainly cases where we have to make exceptions. I just reviewed an article yesterday on lung transplant recipients. This is especially important to our lung patients. in comparing a group of lung transplant patients that were immunized and those that weren't immunized against COVID. The patients that were not immunized against COVID had a 15% rate of death. Those that were immunized had a 0% rate of death in that group. It not only, the benefit of the vaccine is it doesn't necessarily prevent one from getting COVID, but it always decreases the seriousness and the acuity of that illness.
Okay, we had a question from Representative Rosar.
Thank you, Mr. Chairman. Thank you for coming today and presenting your perspective. I just want to springboard a little bit, I think, on the topic that Representative Moses was talking about. You say in your testimony, we saw the rate of death was more than 10 times higher among transplant recipients hospitalized with COVID versus non-transplant COVID patients. I'm just asking you, it's always hard to determine in seriously ill patients sometimes what their actual cause of death was. How comfortable are you saying that their cause of death was because they weren't immunized with COVID? Is that a bit of a giant leap to take?
No, we started a registry and we reviewed every single case of patient mortality. This was prior to the vaccine's availability, so we had a pretty pure population there. We knew that no one had received the vaccine. And UNOS actually reported they had thousands of additional deaths over their expected. They produce statistics on a semi-annual basis about the number of expected deaths they have. And so we are very, very confident in that. Our rate was 21 or 22%, I don't recall right off the top of my head, based on those patients that we followed just in our hospital, that were admitted to our hospital, and we reviewed every single case.
But you said in your testimony, and I absolutely agree with you, that people who are on immunosuppressant drugs have a decreased immunity, so that would automatically put them in a high-risk category. And just because of their transplant status, they would also be a high-risk patient for death from COVID because of, we all know that there were certain things that caused people to be more likely to die with COVID than other things. Sure. So I would have to think about that and really look at the statistics a great deal, because just because somebody didn't have the COVID, because they're already in a high-risk category for death from COVID. So I just question a little bit about if that's not a giant leap just because they didn't have the COVID vaccine, they died. You're telling me it is, and I trust your expertise, but these are sick people.
I do understand your point. They were in a higher risk category already. We did compare our rate to both our internal hospital rate, which was all comers, anyone who was admitted with COVID who died in the hospital, as well as the national rate, which was right around 2.1% during that same time.
Thank you. I appreciate your comments.
You're welcome.
All right, Representative Murphy.
Thank you, Mr. Chairman. I need to question a little bit more along the lines of where Representative Rosar was going. And it seems to me, my question is if you had information showing that because of the lack of the vaccine, that's what made this difference, why didn't you report it that way?
Report it to whom?
To us. Why wasn't that how it was put to us in the testimony?
I apologize if it wasn't clear. We pointed out that it was prior to the vaccine availability, so no one had received a vaccine at that point.
Fine. Okay, that's good. So, question about your criteria. Is weight a criteria?
It's not weighted in the, I don't think in the way that you might be thinking about it. We are required by our regulatory bodies, if we go outside of our criteria, to note why we go outside of our criteria. So there's not more weight, for example, if someone has a body mass index of 65, which would be far above what we
You don't use that, or you do use that?
do use body mass index.
Okay.
Yes.
What about a person's diet?
All of our patients meet with a dietitian. We do not take into account whether or not someone has been perfectly compliant with their diet for their entire life, that sort of thing. That is not generally something that would end up ruling someone out, especially if they were willing to abide by better nutritional standards.
Can I eat a Big Mac every day and still be on the list?
Well, if you're on the list for heart transplant, we would certainly counsel you and provide regular nutrition follow-up so that we could.
Okay. What about exercise?
That is something that we evaluate, yes.
Okay. And that is part of the criteria. If you're not exercising,
That is not part of the criteria. Many of our patients are so ill that they don't have the capability of exercising.
Okay. What about safety kinds of things? What if you don't wear your seatbelt?
That's not something that we ask.
Okay. All right. Thank you. That's all I have for questions.
Right. Representative Subek.
Thank you. And actually, I have a question on behalf of Representative Anderson, who had to leave for another meeting, and he asked that I pass this along, but I'm actually interested to know a little bit more about this. So it's sort of a multi-part question. And you've addressed some of it, but one of his questions, like, are transplant recipients, are they graded? How are they selected? Sort of how do you take all these factors and put them all together? Is it scored? Is it graded? How does that work? And then is vaccination status part of that, which I believe you've indicated that it is? And then getting at the question I actually asked the authors earlier on as well, I said, why would you all consider vaccination status? I'm hoping you could address why it is that that's a part of your overall.
Sure. So I'll try to remember all those as I go through. Sure. The first part of the question, I believe, was if someone's status changes and how that's calculated. It's a little bit different for the different types of organs. Kidney primarily goes by. There's no separate. There are separate statuses. If someone is completely urgent, they have no dialysis access, they are absolutely top of the list. They will get whatever kidney comes available within the appropriate blood groups, that sort of thing. Otherwise, the priority really goes by the number of days and months that a patient has been on dialysis. So that changed a couple of years ago. So we don't have any control over whether someone ranks higher at the list or lower on the list. That doesn't go into the consideration on the UNOS listing. So vaccination status is not included on the UNOS listing. So it does not change priority whatsoever on the list. That is all mandated by UNOS. For our liver, lung, and heart transplant recipients, there are calculations that are based on their clinical data. So someone's ejection fraction for their heart, how well that heart is pumping, if it's pooped out yet. That is something that goes into the calculation. If they are of a higher status, we have patients that are a status 1A, that is as sick as you can be for a heart transplant. So they would get any of the closest offers within 500 nautical miles would come to those patients first. And the whole allocation process has changed quite a bit in the last few years, but there are calculations for the three non-extrarenal organs. Pancreas is on a waiting time, how long they've been on the list status right now. So we don't control, we have to report objectively what the patient's clinical data is into the unit system, and the system ranks them when organs become available. So we don't control that. We get audited to make sure that we put everything exactly as it has shown up in the diagnostic testing into the system. So there are many, many double checks on that to ensure that we're reporting appropriately.
And can you speak to why you take vaccination status into consideration?
We do because of the risk to the patients after transplant. Having seen so many patients suffer for quite a long time after after their transplant and something that was vaccine preventable. We felt our entire leadership group and the leaders of all of our transplant programs met and determined what our approach would be on that. We do also, I'd like to say, we are upfront with patients when they call to be evaluated for transplant. We do tell them what our current requirements are. They have the option to go to another transplant center. If a patient was already on the list and we put a requirement in place for sometimes patients on a kidney list, for example, might wait for quite some time. We found other transplant centers that did not have the mandate. We sent records to those centers. We tried to assist them in getting listed. We certainly do not intend in decreasing access to transplant. We want the best for those patients.
All right, and one last question, which is, I know that the topic of ethics has come up in some of the testimony. Can you speak at all to the role that that ethicists or others with expertise within that realm plays in how these decisions are made or how these policies are set?
Yes, we have a COVID management committee that we talk to specifically that has legal ethics, a broad set of disciplines about the vaccine and what the data was. We also have recommendations from the American Society of Transplantation, which is one of our major societies, and the International Society of Heart-Lung Transplantation, both of which strongly recommend vaccination, and actually ISHLT, the International Society, strongly recommends that family members in close contact also get vaccinated. So we posed quite a bit of our approach after the recommendations that we were getting from these broad thousand member societies that had access to the global data.
Thank you.
All right, Representative Dietrich.
Thank you, Mr. Chair. Thank you for being here. Question to you, is there anything else in your criteria that would prevent somebody from being on the list? What other things, besides not having the COVID shot, preclude you from being on the transplant list?
Oh, sure. Existence of a current cancer, for example. If someone had it depends on the type of cancer. If someone had breast cancer, for example, giving that person, we wouldn't put them on the list. If they had treatment, there's generally a waiting period to ensure that giving them a big, strong dose of immunosuppression doesn't make that cancer come back in a form that's absolutely untreatable. We talked about body mass index. Most of our programs have an upper limit for body mass index because of the data that shows the complication and mortality rates are much higher with higher body mass index rates. Current infections, if someone has an untreatable infection, we have many antibiotic resistant infections out there right now. That is something that might preclude them from getting on the transplant list.
All right. Thank you.
Representative Murphy.
Thank you, Mr. Chairman. Could you tell us how many people have been removed or denied access to the transplant list over the last few years due to their vaccine status?
Yes, I can tell you we have not removed anyone from our transplant list. There are 14 patients who opted to become inactive rather than receive the vaccine. Those patients, we personally assisted them in identifying other centers that they could go to. I can't tell you exactly how many have been turned away because we present that information so early to patients. I'm sure there are patients who have heard that information on the first phone call that is something that we usually require and opted to go elsewhere or opted not to proceed.
So for instance, I mean, you have 14 patients that, once the criteria was laid down to them, said, well, I don't qualify.
They are still on the list.
We had a woman here,
Yes.
a lady testifying about her son. And,
yes.
Yeah.
Yes, and in that case, when I listened to her testimony, it sounded like that her son was not yet on the list. And so that evaluation may have occurred at the time that our requirement was going into place. We have not removed a single person from the list. We've given them options.
What would those options be?
We have talked to other transplant centers in our area. We have, between the 3 other transplant centers in the state. We also have, I believe there's 8 transplant centers in Chicago. So there are plenty of options down there. We work very closely with other transplant centers. We've talked about BMI. If we have a patient with higher BMI, we know that there's a center in Chicago that does not have a BMI limit. They're one of the only ones in the country. And so for that particular organ, we refer patients down to that center. We call them and say, hey, we've got a patient for you. We're going to send you their information. And so we work very closely to try to get all patients. I want to see everybody transplanted. I'm a recipient and I have benefited from it tremendously. And so that really is our goal, to give access to everyone that we can.
Thank you, Mr. Chairman.
All right. I have a question. Do any of the organizations that work with the hospital receive funding from the biopharmaceutical industry?
I don't know that. That's not something that I can answer. I wouldn't be privy to that information, not to my knowledge.
I just asked because, obviously we're always looking for like conflict of interest on these things as well too. So you would not know that. Okay. Do we have any other questions? All right. Hearing none. Thank you for your testimony. And unless I'm missing someone, that is all I've got for people speaking on Assembly Bill 955. I do have registering against Connie Scholze with UW Health and UW School of Medicine and Public Health. And I've also got Mark Grappentine with the Wisconsin Medical Society registering against as well. So we are moving on to our final 2 bills here. So I'll invite the author of the bill up. Representative Sortwell is going to be testifying alone, and he's going to be testifying first on Assembly Bill 609 and then followed up by Assembly Bill 611. So,
thank you very much.
It's all yours.
Thank you very much, Chairman. And these 2 bills really are pretty interrelated, and so it makes perfect sense to just take these together. I appreciate the opportunity to testify before you today about 609 and 611. 609 is relating to prohibiting the discrimination or retaliation against healthcare providers by healthcare entities and credentialing boards for ordering or discussing innovative or novel therapies. For much of the last few years, there appears to have been a coordinated effort to censor information, suppress the use of cheap, generic, and off-label drugs for outpatient treatment, notably of COVID-19. Despite a substantial body of scientific evidence demonstrating efficacy and at very least the safety of safety profiles for many of these treatments, in addition to the longstanding practice of clinicians prescribing medications for off-label use. I want to emphasize that again. This has been in the medical practice for decades, that they have been able to use safe medications for off-label use if in their professional judgment it was so warranted. This is not new. But there's been a growing number of incidents in Wisconsin across the country where healthcare professionals were either terminated or subjected to disciplinary action, threatened to have their jobs or licenses terminated for deviating from unaccountable federal bureaucrats' treatment guidelines. I stress guidelines because they are not law. Guidelines are not law. Many continue to speculate as to the exact reason why the judgment of these healthcare professionals has been actively suppressed. Are we not supposed to trust the science and the expertise of these highly educated professionals? Is it not contrary to the principles of science that by suppressing that we are suppressing the challenging of the status quo? That is science, challenge of the science quo. Challenging the status quo. Regardless of the forces behind this troubling trend, AB 609 seeks to reverse this unprecedented level of interference with the physician-patient relationship. Whether it pertains to COVID-19 or any other disease, we shouldn't continue to allow this type of practice to continue. So with that, I will move on to AB 611, unless you want me to do that right away, or take questions on 609.
Let's go ahead right away.
All right. So 611 is similar, but from a different perspective. So 611 relates to the right of healthcare providers to express their professional opinions related to health or medical information or guidance. So while the first bill was about them specifically prescribing off-label drug use. This one is about them being able to express their medical opinions. I would think it would be very important to any of one of us that we know our doctor is able to express what that his or her opinion actually is, and is not being told he can't say that because it's not approved thought. I think that's a very dangerous road to go down, the idea that we only have approved thought. Since being elected to my first term, I have received contacts from medical professionals in my district who are concerned that if they expressed their certain professional opinions, their licenses, certifications, or their jobs would be threatened or terminated. As a matter of fact, I still have one of those complaints that was submitted to DISPIS sitting in my desk because I don't want to forget it. I still have a copy of that sitting in my desk right now. Their practices are being jeopardized if they dare to challenge the echo chamber and choose to fulfill their sacred duty to speak out as best they understand the science, using their, to quote, greatest ability and judgment, as it says in the Hippocratic Oath. AB 611 protects these individuals by prohibiting any healthcare entity and credentialing board within the Department of Safety and Professional Services from punishing or discriminating in any form against medical professionals who express their professional opinion to a patient or to any other individual. With this bill, medical professionals in Wisconsin will be protected from any employer or licensing board or agency that attempts to unjustly punish them for simply upholding their oath to do no harm. Let's make it a legislative priority to protect the medical rights, freedoms, consciences, judgments of all our medical professionals who are working hard to bring the facts and science to light without fear of retaliation. That's why these two bills are so interrelated and why they are so important. One is about making sure that and I think the committee would agree, we want doctors to be able to be doctors without fear of retribution and silencing, and we want them to be able to prescribe what in their professional judgment is best for their patient. With that, I will take any questions the committee has.
Yeah, thank you, Representative Sortwell. And, last session, I know I worked on you a little bit with these. Can you explain kind of why they were separated out? Because originally these were done, I believe, as one bill, and then they got separated out. And what was the reasoning behind that?
Well, as you know, through the legislative process, sometimes there's disagreements on some parts of the bill for some people. So some people don't like one part of a bill, and another group of people may be against the other part of the bill. But if you separate them, then sometimes you get enough support to pass both bills. So there's that going on. And so we want to make sure that that's going on. There's been a change on the on 611 also because there were some concerns from the state Senate last time around, and so we weren't able to get that all the way over the finish line on the Senate side. We've addressed those concerns, and so I would hope that we could get that to move now. So there was, you had to separate those things out just to get the support you need.
And you covered it a little bit, but why are they even necessary? Shouldn't we just trust the medical systems and the governing boards and the bureaucrats on these issues?
Well, on the one hand, I touched on why it's so important, and I think most patients, when they go to the doctor, want to know that their doctor could be honest with them. I mean, do you want to go to the doctor and know? Would you go to a doctor knowing that he or she can't actually tell you what they really think? I mean, that's not what you want from your doctor. That's not what you want from your healthcare provider. But it goes beyond that. The idea of science is that it's always changing, and that if you're not allowed to have dissenting voices, you don't make progress in science. So we of course would allow for people, if they're doing something completely reckless, of course that could still be dealt with. But simply not allowing people who have a differing opinion, and yet it is justified under the facts presented to them, and they're doing their research, it is irresponsible not only to the individual patients, it's irresponsible, and it is irresponsible to society, because we need progress in medicine. We need progress in science. I mean, look at all of the different things over the course of years that we have thought at one time or another. And because somebody challenged the status quo, we found out that it was wrong. I mean, at one time it was believed, and this is crazy to think about for us now in modern society. We think, oh, those people back then must have been stupid. But no, they just hadn't figured it out yet. At one time it was believed that flies came from rotting meat. And a scientist said, I'm not sure that's right. And so they tried to figure it out, and they went through the experiments, they went through their challenge, the status quo, and they found out, you know what, that's not right. That's not where flies come from. And there's, the idea of sanitation. There was a challenge of status quo at one point. At one point, it was thought that, it wasn't important to wash your hands before performing surgery. And then people were doing it, and all of a sudden they figured out that, wait a second, maybe washing our hands is actually going to prevent disease. That was a challenge of the status quo. We think of it as accepted now, and it certainly seems to make a whole lot of sense now, but it wasn't when it first came up. If we are going to have progress in society, we need to allow dissenting voices to be heard.
And last I checked, the First Amendment has not been repealed yet either, so we were able to still speak our opinion. So I have a feeling Representative Murphy might touch on that too, but Representative Murphy had a question.
Thank you, Mr. Chairman. So, thank you, Representative Sortwell, for bringing this bill and for working with me. I brought a piece of legislation similar to this in the last session, and this idea came to me from my very best friend, and my best friend is a retired emergency room physician, and what he said was, he said to me, he said, Dave, he said, there was a time when doctors were considered medical scientists. He says, I don't know if that exists anymore. And it has to do with the fact that I think it's big medicine, it's corporate medicine, and the money that keeps doctors from being able to practice their craft with their patients. And as far as I had known, and I asked him about it, he said, well, aren't doctors allowed to prescribe a drug off-label for, it's an approved drug, it's safe, and he said, well, it always has been that way.
Yeah.
It always has been. But suddenly, and what concerns me about this is it's the fact that these are all new precedents that are being set by COVID. Suddenly, because of COVID, all the things that we were able to do in the past are now gone.
Yeah.
And it's interesting because it isn't for everything. It's only for certain things. For instance, Ozempic. We see it advertised on television over and over and over again. It is a diabetes drug. But what is it being off-label prescribed for? Weight loss. And so I gave a little bit of a testimony here rather than asking a question, but if you'd like to respond to my comments, I think
I would respond to that because
since I let you be the author of the bill, I didn't get a chance to testify.
Well, Representative Murphy, the difficulty of where I think the healthcare field is in general at this point. This is far bigger than COVID-19. COVID-19 brought some of the issues to light and started to, as you said, establish some of these precedents and kind of solidify what was already starting to occur. And this is not a knock necessarily on any particular hospital or hospital group, but the hospital group is first and foremost a business. That's not a knock. I honor businesses for what they do. They are trying to make sure they're providing the service and getting the money that they need in order to continue providing the service. That's what a business does, whether it's in medicine or you're selling hamburgers. Your Big Macs you were mentioning earlier. By the way, here they're bringing back the double Big Mac if you want to get on that. So
what a great country.
So it's nothing against that, but it's starting to. What you're starting to see is the removal of that doctor-patient relationship. The ability of the doctor to actually be able to truly engage one-on-one with their patient and make decisions based on that patient alone. Because the business is going to run the numbers. They're going to look at, if we got 10,000 patients and we do X, Y, Z with 10,000 patients, overall, we're going to get the best results from those 10,000 patients. That's what they're going to do. And there's nothing wrong with that basic concept. But if we're disengaging the judgment of the medical professional himself or herself directly, we're no longer treating those patients as individual people. And individual people react differently to different stimuli, whether it's different kinds of chemicals, different kinds of, you were talking before with the transplant individual here earlier. I mean, about diet and such. I mean, some people can eat Big Macs every day and they're going to be just fine. There's some people who can't do that. There are some people who, go running every single day and yet they still just can't manage to take off the weight. There's people who can take certain types of medications and have bad reactions to it. There's certain people who, even if they don't have a bad reaction to it, it doesn't do them any good. And so we need doctors to be able to treat patients like people and not just numbers in the system. And unfortunately, what we've seen over the last few years is a solidification of that movement in medicine to start to treat patients not like individual people, but just statistics.
Well, and I think way back to the early 1980s, and I was working in the dairy industry, and I became aware of a new drug out there called ivermectin. It's been used for industry, and I think people because even my daughter had said this to me, very ignorantly said, well, you want to give them some horse medicine. To which I said, are you kidding me? Almost every medicine that's out there is used cross-species between animals and humans, so that's a ridiculous thing to even say. And I think it's between ivermectin and hydroxychloroquine, these are two medications that are outstanding medications. They are extremely safe. Ivermectin won some award for being one, I think it was through the UN or something, being one of the best drugs out there. Mm-hmm. But both of them are well researched. Mm-hmm. They are extremely safe. And this is where my doctor friend was complaining, because he said, I think ivermectin could help a COVID patient. He said, I'm not 100% sure of that. But I'm 100% sure that ivermectin is safe for that patient. And so if it has a reasonable chance of being helpful, there's really no downside to it. And this is where being a scientist and being able to balance the risk and reward factors, and again, we talk about big medicine and the money in it. Ivermectin and hydroxychloroquine are dirt cheap. Mm-hmm. These are medications that, and so that's what is really concerning about this whole thing, is about it seems like if there's medications out there that somebody can't make a boatload of money on, then there's a bit of irony, a disappointing irony in this situation here, because for the most part, it looks like we've more or less moved past COVID-19. So this, even though we cite that, we're not really talking about COVID-19 for the most part anymore. This is about the relationship that doctors can have with their patients going into the future. And the irony that I see here is that, as on the one hand, at least some people are okay with this restriction of doctors as it relates to being able to make these decisions on something that, in that instance, was just, it seems so almost silly that they were objecting to it, because if nothing else, it was placebo. I mean, because it was so safe, as you pointed out, as far as just a drug. If you took it and it wasn't benefiting you directly in any way, it certainly wasn't hurting anybody. But at the same time, this legislature is, I think we were the first, weren't we the first in the country to pass the right to try
laws for drugs to say, if a patient wants to be able to take something because, they're looking for something and now we're discussing, and I know there's debates about it, with different groups of people, but now we're seriously considering taking up something that, like medical marijuana with the idea of allowing patients to have access to a substance that not everybody's agreed on.
Those things are based a lot on safety. I mean, the first thing with right to try is to make sure that the drug is safe.
And so we have historically, as a state, said we want to allow patients to make these choices in consultation with their doctors. It looks like we might be going forward with that again in another substance that isn't FDA. It's not even FDA approved as a drug. Right? Marijuana is not an approved drug. I mean, there is one pill, but for the most part, it's not an approved substance. And yet we are moving forward with this basic idea that says we are trying to say that we want patients to be able to engage and make these decisions and not simply have administrations, whether it's governmental administrations or hospital administrations, hamper the ability of the doctor to engage with their patient.
Thank you, Chair.
Okay, I left a lot of leniency and did not infringe on any First Amendment rights, but I was still waiting for a question there. So I think Representative Dietrich had wanted to express her First Amendment question, so. Yeah.
I actually have a question.
All right.
And keep the answer tight.
I'll try. But I'm a politician.
Not all of us talk as much as others. My question is this. You're talking about this legislation in the context of COVID-19. Are you aware of any other illnesses that have been treated this way with medical professionals?
I am not aware of another single disease that I could point to that was treated in this way, where they were telling doctors that they couldn't prescribe what in their judgment was best for their patient. I have heard from doctors kind of anecdotally in the conversations I've had about this that they have been limited in what they were allowed to recommend to their patients, but they didn't give me it's always on XYZ disease or whatever.
Or specific medicines? Is that what you're referring to?
I remember the conversation. I don't remember the specifics. I'm sorry.
Okay, thank you.
All right. Do we have any other questions from committee members? Representative Brooks.
Thank you, Representative, for bringing this forward. I'm sitting here trying to work through this balance between going to my doctor and having a doctor-patient relationship and making sure they're being an advocate for me, and also putting on my employer hat.
Sure.
So let's say I'm running a nonprofit religious hospital.
Mm-hmm.
I have a mission statement.
Mm-hmm.
And now all of a sudden I have physicians that are going against my mission statement. And I'm going to use a controversial subject, not just medications and stuff, but we've had hearings on transgender surgery and puberty blockers and stuff like that. So I, as an employer, couldn't stop you then from doing that, even though that's completely against my mission statement, the way I read this bill currently. Or conversely, if I'm going to your scenario, I am a facility that is bought and paid for by Big Pharma, to take it to the other extreme. How do I know my doctor's doing that? It becomes a very slippery slope when we say you can do anything, say anything, as long as you're not harming the patient, because harming the patient is different, as we know in this building, in your opinion versus mine versus somebody on the other side of the aisle. I won't pick anybody out today, but it becomes a very slippery slope when the employer has all the liability for their employees, but can't dictate restrictions on, obviously if they're committing malpractice, but what do I have a doctor saying, you don't want to do that, go take cocaine instead?
Yeah.
Clearly illegal, but they could recommend that.
Actually, cocaine can be used for medical purposes.
Representative, I'm not arguing that point. You know where I stand on marijuana. You know where I stand on a lot of that. I'm more of a libertarian, but it becomes a slippery slope. You can't say doctors should be able to say anything, do anything, unless I don't agree with it.
Sure.
So a doctor that says, oh, no, I don't think you can have that transgender surgery,
Yep.
or puberty blockers are bad, or conversely encourages those
Yep.
things, but totally flies in the mission statement of that healthcare provider, how do you walk those areas back then?
Absolutely. So those were really kind of two questions. There was the liability standpoint and then the kind of the ethical issues. We'll tackle the ethical issue first because that one's pretty easy to fix. Last session, we did not have this section in here, and this is part of why I didn't go past the Senate, because they had the same concerns you have. But in Section 1, subsection 3, we specifically lay
Which
out
bill? Sorry.
Of 611 related to sharing your medical opinions.
Okay.
It says, that the section does not apply to entities that are faith-based religious institutions that have published religious, moral, or ethical policies. So we protect the First Amendment rights of those organizations related to their religious beliefs. So that's the first one. I'm
going to interrupt you for a
Okay.
second. We just had UW Health testify about vaccinations, and that could be a disqualifier for transplants. So that's UW Health's policy,
Mm-hmm.
and now you as a provider are saying, no, I'm not going to worry about it. I mean, do you understand where that could be a problem if you have employees of a facility flying in the face of the policy of the place? You're an at-will employee. If you don't want to work there and you want to become a holistic doctor, you can go there. I'm just trying to work through that as an employer's rights to say, or an employee to say, you can work here, but these are my policies. If you don't agree with that,
I appreciate that. And like I said, we did protect it as it relates to the actual First Amendment, as it relates to religious beliefs. The problem with what we are facing related to not pushing back on this somehow is we have systems that are kind of, I wouldn't say that they've actually collaborated. I'd be surprised if they actually did that. But they've all come to this kind of consensus, and they all come. And so, where does a doctor go? I mean, yes, you can open up a private practice, but that's a huge thing. I'm not saying you can't do it, but especially if you're a young doctor just starting out from medical school, you don't usually open up your practice right away. And so, usually you're going to go work for a hospital or whatever for a short time, or for at least a short time, because you just spent however many hundreds of thousands of dollars on medical school, and you don't have another $1 million to go start your private practice. And so, while we protect the First Amendment rights of the businesses, I don't necessarily have the same level of sympathy for just the business just decided that they're okay with suppressing the medical opinions of the doctors they chose to hire. So that's just where I am on it. We may disagree. On the liability standpoint, the liability issue that you brought up, the primary liability falls on the medical professional themselves, the doctor. They carry the malpractice insurance. Yes, of course, hospitals can be sued. It happens. But the primary fault lies on the doctor. And if the doctor is saying that, in fact, that they believe that this is the best treatment, they are taking on that liability themselves in addition to the hospital. The hospital may take on some liability as well. But I mean, in general, that's true anyways. And I just think that if a doctor is willing to take on that liability themselves and put themselves at severe financial risk, because at some point, if you keep doing things that result badly for your patients, you're not going to be able to have malpractice insurance anymore. If you don't have malpractice insurance anymore, you're not going to be in practice anymore. And so the insurance aspect will fix the issue one way or another if the doctor is actually being irresponsible, because they're not going to be able to stay in practice. Whether it's at a hospital or private practice, they're not going to be able to do it because they won't be able to afford it.
okay, thank you.
Representative Subak.
Thank you. Regarding the liability issue, I think it's rare that we see a lawsuit regarding an incident that happened in a hospital that doesn't name the hospital as one of the defendants. I think that liability really is at very least shared with the hospital, which certainly makes me think they should be able to take steps to protect themselves. But I wanted to ask, who ultimately is responsible for the quality of care? If somebody's part of a medical group or part of a hospital, patients are choosing where to go, and part of that is based on the individual physician. But part of that is often, if you're going to the hospital, you're not choosing the physician you're going to see within that hospital, but you may be choosing the hospital based on its reputation, based on its quality of care that's promised, based on its mission. And so I guess I'm trying to figure out how you reconcile that with allowing with taking away their ability to set policies that would impact the quality of care received by patients.
I can certainly see that perspective, Representative. So to answer your first question, your basic question before you got to the rest of the bigger question, who's ultimately responsible? Well, I would argue that the first one who's ultimately responsible is the patient. The patient is ultimately responsible for the healthcare choices they make. I mean, whether it's diet or anything, whether you get the COVID shot or anything else. Ultimately, you do have that responsibility. That being said, how many patients are aware that when they walk into a hospital, their doctor can't just share their own medical opinion? Are they really are they even aware of that? Because when a patient walks in and works with a doctor or a nurse, et cetera, especially after the first couple of times they see them, they start to develop that level of trust. But is that trust misplaced if that person can't actually be honest with them? They are bound by the system they work for or the government, depending on which bill we're talking about here, bound by one of those restrictions to not be able to actually give their actual medical opinion. I mean, regular people going about their lives don't stop to consider, I wonder if the government stops my doctor from giving me their own opinion. Now, hearings like this can help with that, and I hope it does that get out there that, in fact, I think the general public would really like to know that their doctors could be doctors and not just cogs in a medical wheel. This is about restoring that so that you can trust that at very least your doctor is doing their level best to treat you as best they can without that restriction.
So I know you and I have a little different opinions sometimes on regulatory issues, but going back to that ultimate responsibility in the case of the government, one of the functions of government is actually to provide that layer of regulatory protection. And so this, I think, I guess I'm trying to figure out how this doesn't undermine the ability of, for example, our medical boards to be able to ensure the level of quality based on standards. I worry that this undercuts their abilities to do that it undercuts the abilities in the case of a medical group or a hospital of being able to maintain certain standards. I mean, I do think most people don't know. I mean, I know when I had to choose a doctor, right, and I go into my medical system and you have some limited choices due to your insurance, right? You go through that whole thing, right? The best I could do is kind of look at where they studied and get some sense. I could ask around for recommendations. But ultimately, I don't know medically a lot about my physician when I first choose them, but I do know that they're licensed by the state of Wisconsin. I can look and see whether there have been infractions or places where they haven't abided by rules. And I know they worked for the UW Health System, which sets certain standards. I know a lot about the quality of that system. If essentially the doctor would no longer be governed in some cases by the standards of those things because we'd be creating this exception, how can I then trust in those systems?
Well, first of all, I would say that they've already been approved by the government to be a doctor. We didn't just take Joe Schmo off the street and say, here, go ahead and prescribe medicines. They've already had to go to medical school. They've already had to have their what is it, residency it's called? Had to have their residency. They've already been approved as being by the Department of Safety Professional Services and the board and the medical board as having completed all the requirements for being a doctor. So we've already done all those checks. And now we are saying we are trusting your judgment that we've now checked and make sure you're not some kook to be able to make those decisions going forward. And I would, as a general rule, I don't know where everybody else is, but as a general rule, I would rather trust the individual doctor to make decision, to recommend, because it's still my decision as a patient, but to be able to recommend the treatments that they think are best for me as a patient than a slow-moving, bureaucratic morass that is government. That's where I'm at on that, and I would trust the individual doctor 365 days a year and an extra day in leap years. Yeah.
Fair enough.
All right, and I will say, you know, and I easily could have joined Representative Sortwell down there because I testified on one of these bills last session. And when these first came to my attention by you, it intrigued me, it got me interested, and I'll keep this short because I've let it go a little long here today, but I have two specific incidents of medical doctors that are trusted colleagues of mine. One, this happened prior to COVID, so about 2017 probably, and then the one was after COVID. Both of these doctors worked for a very 90% of the population or more highly respected medical institution, research institution that maybe is based out of Minnesota and has a home in Arizona and Florida as well. But very respected, does a great job for the vast majority of patients. Both of these colleagues of mine left that institution because their opinion was being squelched. They were not allowed to work outside of the protocols. And this is not unique to this one institution, so I don't want to pick on that one. But I believe, and it was touched on a little bit with the malpractice coverage insurance, if they're being irresponsible, it's also very much consumer market driven. These two individuals, because of non-compete laws by that institution when they left, had to move outside of one of my communities, I won't narrow it down, and practice 30 miles away. They have people driving from my community, and they're both in separate independent practice, both established doctors. You address that, you know, coming out of school, you probably don't have a lot of capital to start your own practice.
Yeah.
Both of them have waiting lists. One of them, I had a patient I referred over there for a medical thing because chiropractic doesn't work for everybody, for every condition. Referred him over. It was a 6 or 8 month waiting list to get into this individual. Because, and obviously they're not a quack, because, you know, if I deliver an adjustment or treatment that has an adverse reaction in my community, I'm not going to be in business very long on some of these. The word's going to get out that I'm a quack or not a real doc or whatever you want to call me. But it is very much market driven. So I do think there's checks and balances in here, you know, just from the general public. You know, if it's not the right treatment or these docs are hurting people, and you address this a little bit, they are licensed. They had to go through the education, the credentialing to become a doctor. And if they're doing stuff that's way outside of realm and not getting successful outcomes, they're not going to be in business anyway. But that was my question, and I'm sticking to it. So any other questions from the committee? Yep, Representative Sapek.
Representative Sortwell, it's nice to see you.
Good to see you.
I just have one really quick question. I am going through this, and I keep finding myself putting the word experimental into the place of innovative therapies. And you and I are on the same side for, I think, a lot of things in this building. But I'm curious about the line where we talk about the pubertal development in a minor for the purpose of assisting a minor with a gender transition. Well, I'm on board with you there. I'm wondering why you specified that specific thing instead of just taking minors out of this and saying that you can't use these innovative or experimental sort of therapies on any minor at all, and you specified specifically the transgender puberty blocking.
So if I understand your question correctly, you are asking why I specifically said that the sex change therapy, whatever you want to call it, drugs are not allowed under this bill, but rather than I could just say no novel therapy can be used for minors?
Correct.
Well, simply put, because there are minors that sometimes are sick, and sometimes we have not necessarily found, you know, there may not be an immediate, obvious treatment that the entire medical community is agreed upon for that. I mean, you know, COVID-19 is a bad example because, of course, kids didn't really get seriously ill from it or die from it. So in this instance, so related to COVID-19, it's just not terribly relevant. But, related to things like right to try and such, I mean, people have used other medications such as, whether it has THC in it or not, but they've used other cannabinoids to treat children, and it has been effective. And it's not necessarily an FDA-approved drug, right? And so I didn't want to necessarily, I didn't want to hamstring the doctors in that way and simply say you cannot do this at all if I would like you to be able to use that judgment. Now, as it relates to why I did have this prohibition in here related to the minors and sex, gender therapy, as some people like to call it, I just straight up have I think it is a shame upon our society that it is happening to our children, and that's where I'm at on that issue. And so I do not want to create a loophole that allows for people to, in my view, brutalize children. So I was fine with having that as a restriction on there. I mean, I don't know where the committee is at, don't know where the whole legislature is at, but that's where I'm at, because I do not believe that, whether you're a doctor or anybody else, I don't believe you should be able to, in the name of medicine, cut off perfectly healthy breasts of a young female person. So.
Okay, I'm 100% with you there. I think that I really think that this is a great bill. I'm sorry that I missed it and I didn't get my name on it, but I do wish that it was for all minors, because I think that scrutiny in taking care of our children is #1 priority, as with me as it is with you. But that was my only question. That's my only concern.
Thank you.
Thank you.
All right, any other questions? With that, thank you for your
Thank you,
testimony,
Thank you all.
Representative Sortwell. Last up that I've got speaking in favor is Heather Allen, representing Wisconsin United for Freedom.
Thank you, Chairman. And for the record, I'm, again, still Heather Allen, still representing Wisconsin United for Freedom. And is it okay with your permission if I do read from both of our testimonies from both 609 and 611, Representative Moses? Is that all right?
Yep, that was the plan.
That was the plan. Okay,
Yep.
I just wanted to make sure that we were all on the same page.
Yep.
Nope, that's okay. Awesome. Well, thank you all for still being here. And as I mentioned in my previous testimony, you will often see people from within our organization here at the Capitol fighting for our right to medical freedom and for a patient to decline a vaccine. But we also support bills such as this, AB 609, that give the patient the right to access to medical therapies. This bill aims to help safeguard the autonomy of healthcare providers and protect patients' rights to access medical therapies. The proposed bill includes provisions ensuring that healthcare providers can order such therapies based on their professional assessment and the patient's needs, considering any available clinical data supporting the therapy. Moreover, it requires patient consent, with the patient explicitly requesting the innovative therapy. Additionally, for therapies falling under drugs, devices, or biological products, the bill mandates that the therapy be either approved or authorized for emergency use by the Federal Food and Drug Administration. One of the bill's fundamental principles is to empower healthcare providers to inform their patients about innovative or novel therapies that may potentially benefit them. This provision is essential for fostering open and transparent communication between healthcare providers and their patients, allowing individuals to make informed decisions about their health care. In summary, we believe that supporting this bill is imperative for preserving medical freedom, fostering patient-provider relationships built on trust, and advancing access to innovative therapies. We urge you to support this legislation and stand with us in advocating for a healthcare system that prioritizes patient and provider autonomy. If there are no questions, I can read from the next one.
Yep, go right into the next one, just like we did with the author.
Okay, awesome. Okay, I want to express our support for AB 611, which establishes a fundamental right for healthcare providers to freely express their professional opinions regarding health or medical information. This vital legislation aims to protect healthcare professionals from retaliation, discrimination, or adverse actions for sharing their expert insights, studies, policies, publications, or orders related to health and medical matters. This bill serves as a critical safeguard, ensuring that healthcare providers can exercise their professional judgment and contribute to public discourse without fear of repercussions. By fostering an environment where healthcare professionals can openly express their opinions, we enhance the exchange of valuable information and insights. Open discourse ultimately benefits both medical professionals and the communities they serve. This bill is crucial for promoting a culture of openness and trust within our healthcare industry. In conclusion, we believe that supporting AB 611 is crucial for upholding the principles of medical freedom, professional autonomy, and collaboration, sorry, it's been a long day, within the healthcare community. We urge you to support this legislation to create an environment that encourages open dialogue and the free exchange of ideas in the pursuit of better healthcare outcomes and increased trust in the healthcare system. Thank you.
All right, thank you for your testimony. Do we have any questions from committee members? We're all tired out, so.
I think so.
Thank you for coming down to the Capitol.
Thank you all for being here.
That is all I've got for people speaking on Assembly Bill 609 and 611. So I've got registrations in favor. Aaron Runk, representing Wisconsin United for Freedom, speaking in favor. Mark Grappentine with the Wisconsin Medical Society registering against. And then on Assembly Bill 611, I have Aaron Runk with Wisconsin United for Freedom registering in favor. And then once again, on Assembly Bill 611, I have Mark Grappentine with the Wisconsin Medical Society registering against. It was another long hearing, so I'd like to thank members for sticking around and committing your time to the testimony today. And I will say, once in a while, you know, there's events in our life that remind us why we're down here, representing our constituents and sacrificing time away from family. Some of you may have noticed that Representative Drake was here for a limited time today, so I would like to extend my condolences to Representative Drake on the recent passing of her brother. So if you do run into Representative Drake, I hope that you extend the same. So with that, we do have a hold on next Wednesday for a potential public hearing, possible exec as well. Nothing firmed up yet, but next Wednesday, the 24th as well. So do I have any other questions from committee members at all? Brooks? Representative Brooks? All right. With that, this hearing is adjourned. You look like